DOS backend team, can you let us know when we are ready? Anybody from the technical team is here?
Sir, actually, we are already live. I think.
Sir, you are live. You can start anytime.
So, good morning, friends. I'm Dr. Rohit Chetty. I'm from Bangalore, Narayana Netralaya, and I've been given this very good opportunity to host this program with Dr. A.K. Grover, sir.
Morning, Dr. Rohit.
Morning, sir. Welcome.
Privileged to have this session with you. Wonderfully crafted. Looking forward to this session.
Thanks a lot for taking out from your busy.
Dr. Rohit Shetty is the best known researcher in the ophthalmic field and has wonderful work to his credit, which you've all been seeing with all our journals, national and international. And we're looking forward to this session on innovations. There's nobody better than Dr. Rohit to present this subject, and we look forward to the session live.
Thank you.
Dr. Rohit, please take over.
So, we have crafted this with the help from the DOS Scientific Committee team, a group of very young and very passionate researchers from across the country. And the whole idea is to bring your innovation in 8 to 10 minutes time. And then we can have discussions, and all the audience are requested to send questions on the chat box, and one of us will keep reading it, and in case or the DOS team will backend team will help us with this. I would like to start this innovation session, the Delhi innovation session, with Dr. Amar Pujari, who is a very good innovator, seen his innovation in many platforms across India, and even in the lot of webinars and even in the Zoom-based innovations, he's projected very well as a very good innovator, and we are very, very happy to have you, Dr. Amar. Dr. Amar, and we have not given any names to those innovations because we have allowed the speakers to pick up their innovation, which could be useful for this year. Dr. Amar, all yours.
Thank you, Rohit sir. Good morning, Grover sir. I will be screening my screen now. Is my slide visible, sir?
Yes, Amar, all good.
Yes, thank you, sir. My talk is on anti-segment OCT in post-polar cataracts. We have done some of the research topics on this one. I would like to present here. So why post-polar cataracts are so important? Because these cataracts often have deficient or weaker posterior capsule. So people have discussed so many clinical signs based on which you are able to decipher whether the capsule is deficient or not. But in recent times, with the improvement in technology, people are choosing for a non-contact, non-invasive cross-sectional imaging modality. So in that one, if you search the literature, you'll find these main 5 papers. Apart from this, there are so many case reports and case series, but these are larger subject original studies, which shows that from 2014 onwards, there are mainly 5 papers which shows how to identify the deficient capsule behind that discoid opacity. From Hong Kong to China, and even the Arvind has described their own these things. And if you look at these images on the left side, this is from southern India, so which shows that how to identify the deficient and intact capsule. So these are the all images. So on the left side, when this you can see into this yellow circle, when you are able to see the capsule beneath the discoid opacity, they are going to label it as intact. Subsequently, when you are not able to see it, they are going to label it as deficient, and additionally they are going to correlate intraoperative findings. So this pattern has continued. However, all these OCTs are going to be spectral domain OCTs, which has limited penetration up to the posterior opacity as well as the capsule. So in these cases, it becomes very difficult when the discoid opacity is very dense, whether the capsule is intact or not. So for this one, so many people have tried different softwares. Even one correspondence is there from Turkey, which showed that we can take out these images onto MATLAB software and we can increase the intensity or decrease the intensity. So that's how we can decipher the posterior capsular integrity. Even in this lower image, you can see on the left side, it is showing intact when you are able to see the capsule and the opacity. On the right side, it somehow it is very hazy. That's why they are labeling it as deficient. That's why they are labeled it to the red mark. And intraocularly, there was a PC dehiscence. So similarly, Dr. Ritu Arora from GNEC, they have described something called teardrop sign. So this shows that how the people are choosing for this one. So accidentally, I was putting minus or like negative lenses in front of posterior segment OCT. I wanted to image the deeper aspect of the choroid. However, I failed in that one, but somebody told me you can put 20D also, we'll see what will happen. So I placed the 20D lens, which we routinely use for retinal examination. So then I saw that it is converging the rays and it was able to give the anti-segment pictures. So that it was able to delineate the posterior capsule very nicely. So on the left side image, you can see this collage shows how the modified OCT is able to delineate the posterior capsule and the posterior discoid opacity. In addition to this one, you need to decrease the signal intensity or you can increase the signal intensity. So this is to delineate or this is to reduce the background noise so that we can appreciate the capsular integrity in a very clear manner. Okay, so after observing around 26 cases of post-polar cataracts, so this we presented at ESRS Paris last year. So we found two patterns. One is capsular integrity we need to define at the posterior pole. On the left side, green arrows indicate that in all patterns of scans, the capsule is well defined. So capsule you can make out beneath the opacity as well. On the right side, you can see in the post-polar cataract, the capsule is not defined at the posterior pole beneath the discoid opacity. So similarly, second comes the contour. This is the second C, where the contour is going to be convex in post-polar cataract in all cataract cases. However, on the right side, you can see the contour, the convex contour has been disturbed. So you need to identify the capsule with your eyes throughout the posterior extent and that too specifically beneath the discoid opacity. And you need to assess the contour. On the right side, you can see it looks like definitely the contour has been disturbed. It looks like as if the capsule has breached and the cortical matter is getting herniated into the anterior vitreous. So this consistent observation in 4 eyes out of 26 eyes made us to name this as a conical sign. Okay, in this collage, you can see in all 4 cases, I'm not able to identify the capsule at the most apical portion. In addition to that one, the regular convex contour has been lost. So the red dots indicate how the configuration is becoming like a conical sign or a conical formed configuration is getting adopted. So because of this, we named this as a conical sign. In out of 26 eyes, 4 eyes had this thing and all 4 cases developed intraoperative rent. So we label this as a conical sign. We published it in JCRS. Subsequently, because this is a very limited case series, around 26 eyes, if you search the literature, that has reached up to 80 eyes. So we're not happy with 26 eyes and we wanted to have more number of patients, that is like more than 100, and we wanted to have a more sophisticated technology. So this is the right side image. You can see this is soft source anti-segment OCT that is from Japan, CASSIA 2. So we do not have any financial interest in this one. This tool we have at our center. So I tried a methodology where I wanted to recruit a large number of patients, which will be operated by junior residents, senior residents, and all the faculties. So I included 101 eyes. So the mean age was 52 years. And we defined the posterior capsular integrity as intact in 91 eyes out of the 101 eyes and abnormal or deficient in 9 eyes. So in this one, you can see whatever the previously conical sign, what we termed, that was repeated here. You can see on the left side image, the red dot indicates that definitely there is a posterior ectasia or herniation of the cortical matter. That resembles like this diagram on the cone right side. So similarly, in comparison to the upper image, in the middle image, you can see that the configuration is not going into the lens matter is not going into the anterior vitreous, but rather it is following an intralenticular course. So it appears that somebody has taken a bite from the posterior aspect of the lens. So that's why we label this as a moth-eaten appearance. Dr. Coker used to say he is going to label this one as a more of a fibrotic variant, but fortunately the AS University was able to really reveal these kind of findings in 5 eyes. So this we term as moth-eaten appearance. On the third image, you can see lower image, the ASOCT. All these images have been magnified to 200%. So that is only possible with anti-segment OCT CASSIA tool. Here you can see the capsule on the left side and the right side are not exactly meeting. This diagram resembles the misconstructed bridge on the right side, where the capsules are not going to be in continuum beneath the opacity. So that's why there can be a deficient capsule. So in addition to this one, again, patients were developing rent. So some people described the capsule was very thin, flimsy, we are not able to see, and some people even injected Tricort. So we introspected this one and we found 2 morphologies in patients who have been labeled as intact capsule. On the left side of the diagram, you can see between the discoid opacity and the capsule, there are no hypoechoic areas. It appears that the discoid opacity is densely adherent to the capsule. In contrast to this one, on the right side image, you can see between the discoid opacity and the posterior capsule, there are multiple hypoechoic areas are there. So that indicates that there are existing spaces. The opacity is very loosely attached to the capsule here. So what is the funda between this one? On the left side, you can see the opacity cannot be easily separated. So that means that when you are removing this kind of opacity, you are going to partially tear the capsule. Probably that was the mechanism. On the right side, when hypoechoic spaces are there, that means that when you are doing phaco, probably the fluid is going to percolate beneath these opacity, and that is going to lift the opacity. So that's why it was already relieving the like very suctional force between the opacity and the capsule on the right side. So this we termed as with hypoechoic and without hypoechoic areas, and we classified post-polar cataract based on ASOCT findings. So there are 101 eyes. We term them as either specific morphologies or generalized morphologies. Specific morphologies were around 10%. In that one, conical morphology had 100% PCR rate because there is no capsule, there is a definite herniation of the cortical matter. The second type was moth-eaten appearance. Again, it had 100% PCR rate because definitely there is no capsule, and it appears that there is a lysis of the posterior pole. In the third part, that is ectatic appearance, we had 3 eyes, only 2 patients underwent cataract surgery, so the PCR rate was around 66%. On the generalized morphology, we name them as either with hypoechoic and without hypoechoic areas. If there are no hypoechoic areas, as I said, the opacity is densely adherent, probably you are going to partially tear the capsule, or you are going to have difficulty in taking out the posterior discoid opacity. So here we noted that around 15% of the eyes, that is out of 40 eyes, 6 eyes had PCR. So the PCR rate is around 15%. With hypoechoic areas, as I said, the fluid is getting percolated beneath the opacity, it is elevating the opacity. So that's why these patients are going to have least PCR rate. So this we term as this is the first study on Schwartz-Sohn ASOCT. So this is actually a second post-polar study. Again, this we published in JCRS. The third study was assessment of intraoperative events. When you are doing hydrodelineation in post-polar cataract, how the fluid waves are going, what is happening to the opacity capsular junction, how the hydrodelineation is lifting the nuclear matter from the cortical matter, what will happen if you are like going beyond the golden ring which is formed. So this all we studied here. And in the left image, you can see in one case while doing hydrodelineation that inadvertently fractured the posterior pole opacity. On surgeon's microscopic view, we evidence that one. There is a fracture of the opacity, but we didn't. We were not aware what is the capsular status. But fortunately, IOCT was able to delineate that yes, there is a fracture, and the fluid has exerted pressure on the posterior capsule, but fortunately capsule was intact. Similarly, when you are doing hydrodelineation, inadvertent hydrodissection can happen, that also can appreciate an IOCT. When you are taking out the opacity, there can be a fallacious capsular opening. So that's how you can decipher on IOCT whether it's intact or not. So these are other images how we need to have an intraoperative guidance while doing surgery. So this has been accepted in IGO. This is a post-polar cataract third original article from our this thing. So this has been accepted, and in 1 or 2 months it will appear online. The fourth study, which has been under consultation in JCRS, it describes about morphological aspect of the opacity in post-polar cataracts. So this I will present once it is published. We have done other studies in traumatic cataracts, as well as we have classified the mature cataracts into 3 stages. So we have done around 6 to 7 original articles in different aspects of cataract. Post-polar was a major one, and we wrote a review on this one, and that has been accepted in clinical ophthalmology. So in conclusion, in post-polar cataracts and other forms of cataract, ASOCT has the potential to delineate the clinically important findings. Hence, it is going to be an integral part of cataract surgery in future. Thank you.
Excellent work, Amar, and I think these are all extremely path-breaking work for clinicians today. And ASOCT is coming to our clinic, but very, very nice set of observations you have brought in. Congrats to your team and your mentors for bringing up especially those things. One question, and this questions and discussions for the next 3 minutes is free for all of them. Anybody can ask you questions. There's no award or no best paper for this, so it is just a very healthy discussions and some critical also. Why did you not think about using an ImageJ or one of those math modeling to work on that? Because then you would have probably got a very nice thing. Because ultimately, when you use an image processing and make it better, then eventually you can have a machine reading itself. The machine can build a software to read its own thing. So you don't really need to manually do it, because there is always going to be some repeatability and agreement between two people. Did you
Yes,
think about that?
Yes, sir. In first study, when I showed the modified OCT, that was not standardized. So I confirmed them on image-based software. We don't use MATLAB. Image is freely available, sir. We have used Huang and Otsu. These are the most commonly used algorithms on ImageJ. We have used OCTA studies. So similarly, I used for modified data. So that was like acceptable, sir. It's going to either increase the intensity or decrease. It's going to be better pixelation will be there on that. We don't have any experience with MATLAB, sir. And the soft source has better delineation, sir. Even the recruiter image I tried on ImageJ, so that was like comfortable with that one, sir.
Very good.
Yes.
John, do you want to comment on anything before I ask Dr. Ashok Grover for his comments on this? You've done work on this. John is here.
I just missed the question, sir.
You want to comment anything on this? I said, because it's also your area of work, imaging.
Yes, sir. So, like you said, it is very useful to have it analyzed with the software so that you can precisely measure with ImageJ or any other software. So, I think Dr. Amar has already started work on that. So, that is very useful. And once you have a measurable value, that makes a big difference in science.
Absolutely. Because when you have a measurable value, what happens, Amar, is then when you have a big number, now everybody is going into machine reading or AI.
Yes, sir.
It helps to build into that. Dr. Ashok, sir, any comments on this?
I think this is something which is a direct clinical utility and really nice observations, very easily correlated with intraoperative findings. I think as you do many, many more cases, you can keep documenting them. You will come up with maybe additional patterns.
Yes, sir.
And these observations will really be useful to the clinicians, I think. And the devices that you have innovated and the software that you are using currently, I think once the anterior segment surgeons learn to use those, they will have a much better predictive value for their posterior polar cataract regarding the risk. And
Yes,
they will accordingly be able to prepare themselves for the surgery. I think very, very useful work.
Thank you, sir.
Thank you, Amar. And
Thanks, sir.
thanks for this wonderful talk.
Thank you, sir.
Let me move on to the next speaker, a good friend and colleague, Dr. Sushma Tejwani. She's a glaucoma consultant with us, did her fellowship from LV Prasad, and one of a very bright, she just finished her PhD, defending her PhD. And one of the toughest subjects is looking at the molecular signaling pathways and in glaucoma. And she wanted to go the toughest route of PhD, and she is a hands-on clinician and a hands-on, more than everybody's hands-on clinician. She's a hands-on researcher. This is what people tell me from the lab. She would not send a sample and wait for the sample to come back with report. She would go to the lab and don her gloves and do the work. So over the last 3 years, very inspirational in that. And I keep telling that if you want to be a researcher, you have to be like Sushma. Dr. Sushma, your innovation and translation talk.
Thanks, Dr. Rohit, for that kind introduction and also for giving me this opportunity. I must thank DOS and Dr. Grover as well for the opportunity given. I'll be just sharing my work on a new aspect in glaucoma. You're able to see my screen?
Yes, Sushma, all good, all clear.
Okay, thank you. So this is an interesting aspect. We have not yet heard much about immune modulation in glaucoma. Well, most of the glaucoma management revolves around either drugs or surgeries or laser or say shunts. What we aim at there is controlling the intraocular pressure. So all management is largely revolving around reducing the intraocular pressure. But we do see that almost 10% of the patients still progress despite of best control of intraocular pressure. So we wanted to look at what are the other factors that actually drive the death of these RGCs in glaucoma. which can be useful and can be helpful in managing those or stopping the progression. So there are various aspects which can be seen, and today I'm going to talk about the immunology aspect of it, and I'll tell you why we chose immunology as such. So if we look at glaucoma as a neurodegenerative disease, and immune cell malfunction is actually known in neurodegenerative diseases like multiple sclerosis, Alzheimer's, and Parkinson's. And there are already established treatments for that. So there are immune cell trafficking changes that can be done to prevent these disorders, and there are drugs in the market which are used for movement of T cell egress from lymph nodes to prevent its entry to CNS to prevent these changes. So since glaucoma is on the similar lines, we thought that let's see what happens when we look at the immune cell functions in these patients. The problem, the immune aspect of glaucoma is not very new, I would say. It has been in vogue since 2013. But what is the knowledge gap is that we still don't have much of human data. There is no association with clinical parameters that is established. We don't know what type of immune cells or immune factors that are associated with glaucoma. So that is something which is unexplored. And also it is of immediate clinical benefit because we already have the therapy which can be used for immune modulation. So we only need to find out which one would be useful for glaucoma. Now, how to study the intraocular immune status in glaucoma patient? That was an interesting question. Now, from our previous knowledge, we know that there is movement of cells and immune factors from anterior chamber to retina and from retina to anterior chamber. So aqueous humor is the best sample source for immune monitoring studies in these patients. So what we did is that we took some controls from the patients that were undergoing cataract surgery, and we took glaucoma patients. Basically, we concentrated on primary glaucoma to begin with, so POAG or PSEG. So patients who are undergoing trabeculectomy, and particularly excluding patients which would have other immune modification, things like PDR or retina disorders, Alzheimer's, or other immune related diseases were excluded. So purely glaucoma patients were primary glaucoma patients were taken. And what we did was just simply before starting surgery, we just took a aqueous sample through a 27 gauge needle and preserved it in our grow lab at -70. And then whenever we needed, we could use it for immunophenotyping using ELISA. So what we did is two things from the aqueous humor. One is we wanted to look at the cells, and the second that we wanted to look at the soluble immune factors. Like you can see, it looks very complicated, but it is not. I will just take you through this. Now, what we wanted to do is to look at how the IOP control gets affected by intraocular immune cells and soluble factors. And second, how the RGC or optic nerve gets affected. That means what is the correlation with disease severity and disease progression. So as I said, that we collected aqueous humor from these two set of patients, and we categorized into POAG, PSEG, and also looked at these parameters, which we are all familiar with, like visual field index, pattern standard deviation, what is the RNFL, what is the CD ratio. And we followed up these patients also to look at how the disease progression is. And we looked at the response to intraocular pressure management by drugs or surgery. So one by one, I'll take you through how we did that. Now, these are the cohort details. As I said, there were around 85 POAG, PSEG patients. So patients that underwent trabeculectomy for IOP control, or patients that underwent trabeculectomy because they were poor tolerance to drug or they had to undergo cataract surgery, they had 1 year post-operative follow-up. So we had 49 out of 85 which had 1 year follow-up. So of these, 29 were complete success, 18 were qualified success, and 2 were failures. Now, we also looked at that how their disease progress, that is VFI or visual field index, that was available at 1 year post-operative follow-up. So we looked at that and we found that there were 25 non-progressors and 7 were progressors. Now, to look at what happens to immune cells in these patients. So first of all, we looked at the immune cells. These graphs look complicated, but just look at the fact that controls had much lower graphs than the glaucoma patients. There's not much of difference between POAG and PACG, but what we could gather is that there are certain cells like neutrophils, NK cells and B cells are upregulated or more in glaucoma patients, and monocytes and T cells were less. And when we looked at what does that mean, we looked at how they correlated with the severe disease or less severe disease. So as we had the PSD or VFI or RNFL thickness of these patients, we realized that these cells have a degenerative relationship. That means when these cells are more, the disease severity was more. So if you look at the more severe disease had more numbers of neutrophils and NK cells when compared amongst mild and severe diseases. Now this is about the cells. Now let's look at the immune factors. Now again, there was a significant difference between controls and glaucoma patients, but not so much between POAG and PACG. So we don't have to look at separately at two diseases like open angle and angle closure, but definitely significant difference between POAG and control and glaucoma patients. So what does that mean when we compare these factors with the severity? If you look at now all these red factors that you see, that is VEGF, NGAL, and MMP9, these were higher in patients with the severe disease. And the green factors that you see were lower in patients with the severe disease. So that means the red ones had degenerative relationship and the green ones had a protective relationship. We compared for all these factors, that means the visual fields, RNFL, as well as the clinical evaluation when we compared the severity. So what is the outcome of this particular experiment was that the immune cells had a degeneration, like NK cells and neutrophils had a degenerative relationship, and as I said, the red ones, that interleukins, VEGF, had a degenerative relationship, whereas BDNF and NGF and fast ligands had a protective relationship. Now, the next important question was that whether there is a change in these immune factors for the patients who are stable or who are progressing. So whether we can differentiate. So there are a set of patients who progress on perimetry as well as RNFL. So we looked at those things and compared whether there was a link to the progression of the disease. So now if you look at carefully, there were significantly high IL-8 and IL-23 in patients who were progressing instead of the patients who were stable. And similarly, there was a opposite relationship when we compared IP10 and MPO. The interesting part is the treatment is already available for IL-8 and IL-23 because these are the drugs which are used for cerebral ischemia disorders. And regarding MPO, there are drugs available which are used for psoriasis. So the treatment is already available. So interesting part is that we could figure out those factors which had a significant relationship in terms of progression. Now, let's look at whether there is a relationship in the immune cells and factors with the response to the anti-glaucoma medications or therapy. So when we looked at patients who responded or not responded to the intraocular pressure control therapy, that means glaucoma medications, and required trabeculectomy, again, we figured out that the IL-8 was much higher in patients who had poor IOP control, and VEGF was much lower in patients who had good IOP control. So again, the therapies are already available in these lines, which can be directly used. When we talk about the surgery, the response to surgery, whether the failure or the success of the surgery was also related to these immune factors, very well, we could figure out that there was a significant difference between TGF-beta and PDNF when we looked at the success or outcome of the surgery. So these factors were higher in patients with poor IOP control, and it was also the VEGF. So again, the interesting part here is that for all these things, we can use the immune therapy, which can be predictable, as well as which can guide us towards or improvise the success of existing treatment. So how does this clinically help us? If you look at it, helps us looking at IOP control as well as the progression or neurodegeneration. So the immune modulation can be used along with the IOP lowering medication. It can be used along with the glaucoma surgery, and along with the all current management strategies, we can use neuroprotective agents which can help or stop progressing the disease. So that's a very new direction which can be used for glaucoma management henceforth. Well, I must acknowledge the Narayan Nethralaya glaucoma team, my mentors, Grow Lab members, and Narayan Nethralaya Foundation and Narayan Nethralaya as such, and more importantly, patient volunteers who had helped us do this work. Thank you for your kind attention.
We can go back to the previous slide.
Yeah.
I think we can revolve our questions and discussions around this. Dr. Grover, sir, would you like to comment on this, or this is all open to all the panelists in this group?
Yeah, opens up a totally new vista for therapy, and I'm sure clinicians will make use of that. And very soon we should see the clinical trials, clinical results, and I think the correlation with all the aspects, including the progression, including surgical control, medical control, is really heartening. I mean, that opens up an entirely new vista for therapy, which may be topical, which may be systemic. Topical may come up, which may reduce the possibility of systemic side effects. So it opens up a really new possibility in the management of open angle glaucoma, really path-breaking work. We very much appreciate your work, Dr. Tejwani.
Thank you.
And of course, the team that has made it possible and the setup that has made it possible. Congratulations, Dr. Rohit.
Thank you. What I'm going to summarize in this whole presentation, what you gave in 10 minutes, I'm sure this is your 4 years of your work, or 4 or more, and is that there has to be an angle of immune deregulation or immune differently tolerance in a glaucoma patient. So glaucoma is not only a pressurized disease. You have to look at it from a immune change. See, I think more and more, Dr. Grover, sir, I think you would agree that more and more as we going deeper into understanding of a disease, 99.9%, when in the next 10 years, every disease is going to be defined as an inflammatory immune order disease. The word infectious, non-infectious, non-inflammatory, all that what we've been seeing for the last 100 years, I think will slowly disappear. And this is a classic example of this. I think, are you looking at any of this? I'm sure this is a 5-year work of your very hard work, but you're looking at anything which, Sushma, which been clinically translate, which can be translated from the drug point of view. I just wanted to ask you a question. The neutrophils and MMPs and some of these can be modulated with cyclosporin. I was always a firm believer that when you use a drug like your latanoprost, or one of those drugs which has more ocular surface damage, I did ask you this question, that how, if you do a surgery on a patient who's been on latanoprost or one of these ocular surface damaging drugs, and you do a trabeculectomy, is the success same as somebody on whom you put a timolol or something like that? Because your ocular surface inflammation is being driven so much that you are actually creating your TGF-beta out there. And all those are scar-forming agents. If you go back to the cell biology, if you put a drug for 5 years and then do a glaucoma surgery on him, you have the entire ocular surface is floating with scar-forming agents. Yes. And this is exactly the same thing happened to Dr. Grover's surgery. So you put some of these drops and you do a lid or any of these things, you will get a different response because you have inflamed. And that's one of the reasons I've always been a big proponent that when you use these drops, use lubricants or you use a cyclosporin. I would like to ask this question to you. Do you believe in this concept?
Yes, Dr. Rohit, very well. Actually, when you use prostaglandins for long term, that creates a totally hostile environment for the success of trabeculectomy. So I think most of us glaucoma specialists tend to stop prostaglandins sometime before we plan for the glaucoma surgery. However, some of us, and particularly myself, I use definitely the lubricants along with the prostaglandin, and now I think cyclosporin also. However, the cyclosporin usage amongst glaucoma faculty is not very popular yet. We do use sometimes, if the surface is too inflamed, low dose steroids to prepare the surface for trabeculectomy before we go ahead with the surgery. And that definitely helps in better outcomes.
And for all the viewers, when we use the word lubricants, for a lot of us, it doesn't matter which one you use. For the glaucoma surgeon, do not use the word lubricant, and specifically say do not use a hyaluronate based lubricant. Hyaluronate coats your epithelium cells, so your drug penetration after you put those hyaluronate is going to be very, very poor. Your local bioavailability is going to be poor. So you have to use something which is a non-hyaluronate based, because now a lot of drugs are hyaluronate based. So we might actually make ocular surface healthy, but the patient may not have penetration of your drug. Anybody else in this group want to add, say anything? As this is open for discussion.
So this is very, very interesting. So we still are finding out what exactly glaucoma is. The same with keratoconus, Dr. Rohit Shetty. So we are still learning what actually a particular disease, which we thought for years we knew what it was. We are still figuring out what it is. And so we are figuring out new methods of treating it. Just wanted to point that out. Knowledge is always evolving.
Well, glaucoma has always been an enigma. So how much of vascular factors, how much of inflammatory factors, how much of immune mediation, I think we have a long way to go in learning about this disease.
True, sir.
Sushma, last question.
Yeah.
Let's imagine 2021, you have one chance to pick up one drug, and that drug of all this, what you have put here, will be in clinical use. Gut feeling, which one would you pick up and why? In all this, in this slide which you're shown.
Yeah, so I think instead of one, I will say two. One is an IL-8 inhibitor, and the other one would be TGF-beta inhibitor. Because IL-8 inhibitors would help us reduce progression, or in the patients where we control the intraocular pressure and still they keep progressing. And why TGF-beta inhibitor is that that would significantly improve the outcomes of surgery. So if I have to pick up two drugs, it would be these two.
And IL-2, IL-8 inhibitors will make the ganglion cells to repopulate, or it's just that it will stop it from dying?
Yeah, it stops it from dying.
Because it's difficult for it to repopulate.
Yeah.
Fantastic. It's good. It's something like a ROCK inhibitor in cornea. You are able to help in the cells. I mean, your IL-8 would be something similar to your ROCK kinase inhibitors.
Yeah, we already have ROCK inhibitors in glaucoma as well, already in the market. So
it's more exciting for the cornea surgeons than glaucoma at this point of time, I guess.
Yes, yes.
We have a similar breakthrough in oculoplastics in the thyroid eye disease, where teprotumumab may go a long way in relieving the problems of thyroid patients. Very costly at present, but insulin growth factor inhibitor. So
I think I'm very happy that the world is accepting that there are mediators of inflammation which can be blocked. And the greatest thing which COVID has brought us is even a common man understands what a cytokine storm is.
Yeah.
And any drug XYZ is not something which we should accept, and in the past which we used to do, without understanding this. We had to look for specific blockers, and this is exactly what she's put. This has been my favorite slide of her presentation, is that there are blockers and there has to be ways to do it. And so Dr. Ashok sir, at your level, where your voice is better heard in various platforms across the government and all this, you have to push government to put more efforts into these kind of research, where you look at new drugs to bring in new concept. Otherwise, this is just going to be because every clinicians are not going to take it forward, because it's not possible. We need the help from the pharma and everybody else.
The evidence that you are bringing forth will certainly help.
Thank you, sir. Thanks a lot. The third speaker is Dr. Prakyat. Are you here?
Yes, sir.
Very, very innovative young man, and always love your presentations. And after that, we will go to Dr. Raju, because he has to leave by 11 o'clock, and we all wish to see his presentation. Is that okay, Dr. Raju? Or you want to do it now before Prakyat? Prakyat, are you okay with it?
I am fine with it if he wants to go before me.
Raj, you can finish it so that we don't rush your, we can always have a good discussion, because I don't want to rush this presentation like everybody, we just want to have a lot of discussion, and I want all the panel to get involved. Dr. Raju is a good friend, great innovator, comes from Bangalore, and we have shared many ideas. And this is one of those innovations which I was there when he presented it first time in a Bangalore Ophthalmic Society first meeting, and I'm happy that this translated into a use. And his colleague, Dr. Tirumalesh, who is also one of the innovators today, is already using his innovation. I'm not sure whether he's going to speak on the same, but I'm just saying that sometimes what you present on this group actually translates into clinic very, very fast. Dr. Raju?
Thank you very much, Dr. Rohit. At the outset, I would like to thank you personally and also congratulate you for creating this forum for all of us. Actually, we would have presented our innovations in our own retina sessions or cataract sessions, but getting us all together on a single platform in various conferences, I think I would like to give the credit to Dr. Rohit Shetty for doing this wonderful job for us. And I think the next way forward would be to get the industry also together into these sessions so that we can collaborate and work on these areas and get to the next level. As you said, that whenever we do the surgery, whenever we do our innovations, what our innovations are there, we start small, and sometimes the journey is difficult. That's why I wanted to share my innovation journey with all of you here. I have no financial disclosures. That's because I don't have great bank balances to disclose. But why should one think outside the box? If necessity is the mother of invention, then frustration is the father of creativity. So it all started in the year 2012 when I wanted to start my own private practice, and I wanted to add to my retina setup the non-contact wide-angle viewing systems. At that time, the prices had shot up, the dollar price was high, and they were very costly at that time. So then when I explored the less commonly used non-contact viewing systems, then I found out there were lenses which are already available. That is the PWL lens and the 132 diopter lenses that were available, but they were not used by many. However, the limitation was that these had to be attached to the headrest of the patient's table, and hence it was cumbersome to use. So the idea was to put this onto the microscope. So this was the first prototype, and the concept failed. It didn't work. So I again had to go back to the drawing room and redo the whole thing. And this time the concept worked. So this was in the year 2015. This is the view that I got with the PWL lens. All of us have been using the contact wide-angle viewing systems with the inverters, and this lens has got an inbuilt prism and doesn't require any inverter. And all you have to do is to use this lens and do the surgeries. And this would be especially helpful in tier 2 cities where the cost is a factor when you are trying to invest and expand onto a retina setup. The view I got was quite excellent, and the surgery went on well. And I was very much impressed with this, and then I decided that I should take it forward. So I went back to the drawing room, made some drawings on the rough books, and then used the PowerPoint to make the drawings. All this we went step by step, and then I tried to get some professional help into this. And this is how the attachment looks like after a lot of refinements. And I did an attachment for both the PWL lens that doesn't require the inverter, and the 132 diopter lens which requires the inverter. And this is the current version of what I'm using right now. But all this I have done, but I was not able to show to the world that this actually works very well. So I didn't have my own recording system. Then I started exploring the recording systems. And when I saw the medical grade cameras, these were very, very costly. And if you took the cost benefit analysis at that time, for me, it was not worth it. So again, I started searching for an affordable video recording solution. So then we started to explore whether commercial DSLR cameras or mirrorless cameras are worth trying. So I would like to acknowledge two people here, Dr. Deepak Meghur. He was the first to work with the industry and use a Panasonic GH4 for recording anti-segment surgeries. And Dr. Sumit Kanduja, he demonstrated the use of mirrorless cameras, that is Sony A7 I, for retinal surgeries. And he worked on the low-cost recording systems to show it to his postgraduates. And it was his idea of using the Sony A7S2. So we worked with the indigenous manufacturer to develop an adapter for that, and we used a modular function charts using the LIA paddles, and saw whether the Zeiss adapter and the indigenous adapter matched. At lower magnifications, it did match, but at higher magnifications, there were some aberrations, but it was still acceptable. So then we presented our work at RetNet 2017 and as commercial cameras as affordable recording surgery tools, and also at VRSI. It was at this time we met Dr. Mangatram Dogra sir, who saw our presentation and said that your innovative Jugaad should be validated, otherwise it will die. So then we had to put our system, the medical grade, against the medical grade camera systems. And what we did was, on one side, we recorded the medical grade recording system. On the other side was the our system. So on the left, what you're seeing is the medical grade recording with Sony 3-chip cameras. On the left, on the right side, what you're seeing is the one with the Sony A7S2. So once we saw it side by side, we were pretty much convinced that this was indeed working as good as the commercial medical grade cameras for all practical purposes. So this is the retinal view that you got with the Sony A7S2 camera. So then we went ahead and published our work in the Indian Journal of Ophthalmology, and this was published 2 years back. And our work on mirrorless cameras has also been acknowledged in the Survey of Ophthalmology. And it was also a winning abstract at the Retina World Congress. We are happy to share that almost around more than 200 or 300 installations of this type of adapter given by various vendors is available and is being used across the country now. So just to share a video how good this recording is, I'm just going to show you this short video that we shot on this system. And here I'm again using an innovative technique wherein we've taken the die into the cutter, and using the proportional reflex that is available in the Constellation machine, instead of injecting through a syringe, we are injecting through the cutter itself. So this is a small innovation that we did so as to prevent jet stream injuries. Not only that you can use it on your microscope, you can also attach it to the slit lamp and take excellent slit lamp photography with this camera. And this is a video of YAG hyaloidectomy being performed on a slit lamp that has been recorded on the Sony A7S2 camera. Here, I would like to thank Dr. Saurabh Patwardhan for sharing me with this video. You can see here a YAG hyaloidectomy being done on a slit lamp, being recorded beautifully on this camera system. So as far as doing your innovation is one thing, other thing is to see that you go ahead and patent your work if it is patentable. I went ahead and I have done this patent for the PWL lens. And this was also selected by the AGNI, that is the Government of India, to take it forward. And right now it is also available for use by the retina surgeons. You can contact me personally if you want. And currently I am working on 3D. So right now we have almost completed the prototype and proof of concept for 3D live streaming and recording of surgeries in 3 dimensions, and also 3D slit lamp photography. We have completed the prototype that you can see here, and we have also completed the patent, final patent filing and the PTC for this product. We also would be filing the final patent filing and the PTC for the 3D digital video indirect ophthalmoscope. This will be soon, we'll be coming out with a prototype probably in a year's time. The COVID actually set us back by around 1 year. We are not able to source all the components, but soon I think with the help of industry, we'll be able to do this. So the message for the many young innovators here on this forum is, if you have an idea, however stupid it may be, keep working on it, have patience, and try solving all the problems that you keep getting as and when they happen to us, and do original work and enjoy your work. Patent your work if you have a financial interest in it. That's all I would like to say. Thank you very much for giving me this opportunity. Thank you, Dr. Rohit, for allowing me to present ahead of others. Thank you.
Thank you. Any Retna Tirumalesh and John Prakyat, all of you have worked on imaging, and I'd like to ask, you can keep your questions ready. I would like to ask with Chairman Dr. Grover sir, your comments on this, and then we can go to panel for their questions and discussion.
I'm also a beneficiary of their innovations, and we have been using the system both on the slit lamp and on the operating microscope given by a vendor, which they have designed. So I think they have made a huge difference. I was about to buy the commercial system, and then the young persons in the family suggested, young ophthalmologists suggested that this was a system which was working as good. So we did use it for both our new operating microscope as well as the slit lamp. It's functioning very well, and all thanks to the work by Dr. Raju and the team.
Thank you, sir.
Tirumalesh, are you here?
I've been using the system for almost like, I think we were one of the first ones to get it from Dr. Raju. And it's been working really, really great. One benefit that we were able to see was that it is more and more of customizable, just like you customize your camera. So whenever you change your settings, and along with that, he also introduced us to a new recording system called as the Atmos Shogun. What the Atmos Shogun does is that it enables in these gamma corrections, which were not there in the original recording systems, but the Atmos Shogun did help us in recording 3 to 4 formats, and it gives us the liberty to compress or decompress the file without reducing its clarity. And also a lot of gamma corrections and other corrections can be carried out right there in the OT. So in that way, it's a good innovation. We look forward to looking at his 3D systems very soon.
Thank you.
Thank you. Thank you.
Any other questions?
So that was a great innovation journey. Glad that you were able to tell from the beginning how you were faced with hurdles, how you were faced with problems, and these problems led to solutions which you, so without the problems, suppose you had enough money to buy the more expensive lenses, you would not have come across this, you would not have invented this. So all these problems are the inspiration point for these innovations. So whenever you come across any problem in life, take it as a challenge, and as Sir did, try to find a solution. And sometimes you might think that these problems might be just limited to yourself. So maybe you would think that, okay, while you are maybe you are doing a 90D examination, you get fogging on the lens, you would think, okay, it's just me. But it might be something which is worldwide, and if you devise something to prevent that fogging on the lens, it would be a solution for everybody everywhere. So that is very inspiring, sir. Thank you for taking us through your innovation journey. And I'm also interested in 3D, so I'm waiting for the 3D slit lamp photography and the 3D indirect. I'm looking forward to it, sir.
Yeah,
thank you.
Hopefully next year. Thank you.
Thank you, Dr. Raju. And I would like to invite Dr. Prakyat Roop to give his presentation.
Thank you so much, sir. Is my screen visible?
Yes, Prakyat. Go ahead.
Thank you so much, Dr. Rohit sir and Dr. Ashok Grover, for giving me this opportunity and including me in this session. I'll be talking on a definitive treatment strategy to manage negative dysphotopsia. And this is subject to a patent application, which is currently under review. I'll be speaking on the clinical aspects of negative dysphotopsia, the management strategies that have existed traditionally, our innovation, the negative dysphotopsia ring, and how it has impacted the patient life and our practice. So, negative dysphotopsia is basically a dark shadow in the peripheral field, mostly temporally perceived as an obstacle to a complete field of vision. A lot of people, including many experienced surgeons, ask me if it actually exists as a significant problem. So, to quote the data available from the US and Europe, it has an incidence of about 15% in the early postoperative period, and about 3% of the patients have this persisting problem even at 1 year follow-up, and they would like it addressed. So the patients can come with a variety of complaints that can be traced to negative dysphotopsia. It can be as clear as a concentric black shadow in the temporal periphery, but a less perceptive patient can be as non-specific as an asthenopia-like symptom. So have a look at this patient describing his symptoms with the characteristic hand gestures. So this patient was very specific in telling us that when he used a thick rimmed spectacle, he would negate that shadow, and otherwise that shadow would always nag him. All these patients, you can see, they would always use a horse blinder or an obstacle to show that a shadow exists and they need to block it out for it to be avoided. So after one suspects the diagnosis of negative dysphotopsia, it's very important to confirm it, because there are a lot of neuro-ophthalmological problems that can cause abnormal fields. But an extreme nasal peripheral retinal shadow that is perceived in the temporal periphery after a cataract surgery is likely to be negative dysphotopsia and can be easily confirmed by using a thick-rimmed spectacle or a trial frame tried on by the patient to lessen the symptoms. You can dilate the patient's eye, and that will eliminate or decrease the intensity of that shadow. The patients generally try to use a hand or a veil or a scarf or a hijab to actually use it as a blinder on the temporal side to block the shadow. And those are indicators towards the patient having negative dysphotopsia. Fortunately, when I discovered negative dysphotopsia in my early days of residency, I was already working on an eye model to see if we could improve the results of premium optic IOLs by centering them on the visual axis. So we used the same eye model and fashioned a peripheral pencil of rays coming from the temporal side and being incident in the nasal posterior chamber to realize that the square edge of an IOL placed in the bag was actually causing a shadow in the nasal periphery. And I was pretty sure that this is the cause of negative dysphotopsia. Then I looked back at the literature and I realized that negative dysphotopsia was not a very recent phenomena. It was described and its incidence studied by Davison and published in the year 2000 itself. But as you can see, for a decade and a half, there were only sparsely reported data, although from very good researchers in the West, including Dr. Robert Osher and Maskett Group. But it is only in the year 2017 onwards that there have been so many studies about the causation of negative dysphotopsia, and the debate of that has been put to rest with the ray tracing theory, which was verified by the biometry data and its simulations in the eye by Simpson et al. But the problem arises when you go to the solution. So in the past, counseling has been the mainstay for elevating the fear of losing vision in a patient of negative dysphotopsia. But when it comes to management, we only have proposed solutions that are of questionable efficacy or were very difficult to do, or they had any other side effects that were like having a PCO in 100% of the cases in the group that did reverse optic capture. So they did 22 cases of reverse optic capture, elevating symptoms having about 60% efficacy, but PCO occurred in 100% of the cases. Also, the anti-dysphotopic IOL was initially studied in the year 2011 onwards, but it required a precise centered rhexis, which needed a flat setup generally. And the rhexis margin needed to be tucked into the groove in an IOL. And that changed the current IOL platform completely, so it could not take off. So, we surgeons are very efficient in making decisions. So there's a saying that goes, one of my teachers always says that if you can't do the surgery, at least take the decision of not doing the surgery. So as a surgeon, we are wired in such a way that we would like to close the topic once and for all and not linger on with it. Lacking a treatment option led to us dismissing these symptoms for the patient. So this is how the interaction of a negative dysphotopsia patient goes from the starting that he first day presents with his cataract to the last day. When the patient says that he has a cloudy vision and he has difficulty to read, we state-of-the-art cataract surgery platforms with absolutely no morbidity at his service. When the patient asks that he wants to be able to read without spectacles, we get 6x6 N6 with trifocals and the patient is good. Now, when with these trifocals, the patient comes back on follow-up and says, since the surgery, I have had this black shadow and I can't see the whole view and it is an extremely nagging thing. We counsel them to tell them and to wait and watch, and that this shadow goes away in about 12% of the patients. So we are going to be lucky mostly. But when it hasn't got any better, the patient asks us what to do now. And that is the time we cut a sorry face, because we do not know confidently what to do, how to intervene. And then when the patient asks us that at least make sure that this would not happen in the other eye, again, we do not have a solution. So with the mission to have a definitive solution, an idea occurred to us to have a sulcus-based ring implant that could only alter the behavior of the temporal pencil of rays. That gave rise to the negative dysphotopsia ring, which we simulated, designed, and then with the help of Care Group were able to manufacture. This works by allowing the central rays to go through the intraocular lens completely unaffected by the ring. The rays from the temporal field are distributed evenly in the nasal peripheral retina after getting refracted from the inner and the outer edge of this ring. And that does away with the ring shadow. Apart from that, the ring sits on the anterior capsule, so it prevents any rays from being incident on the anterior capsule at high incidence angles. This is another cause of causation of negative dysphotopsia that is not addressed by many of the other solutions that have been proposed, which is why every solution has only been partly efficacious. Negative dysphotopsia ring showed in our study to be 100% successful with no adverse events at all. It is ergonomically designed with special ring-shaped haptics that have hinge joints so that it can accommodate a large number of white-to-white measurement sulcus sizes without having to actually measure the size. Even in hypermetropic eyes, there is a lot of space in the sulcus to place this device. Also, it does not need any added instrumentations. The surgical time for this implanting this device is less than 3 minutes. We need access through a 2.2 main port. We can open the old phacoemulsification incision, or we can make a new incision. We have to load the device in the cartridge provided and inject it into the AC and simply dilate into the sulcus. Once it's placed in the sulcus, we'll wash the AC of all the OVD and seal the wound. Post-operatively, the eye is always quiet. The ring is seen resting on the anterior capsule. And if you shine a temporal peripheral slit through the mesopic pupil, you see that the ring illuminates in its nasal side. This is the light rays that used to miss the anterior IOL optic or fall on its edge and cause negative dysphotopsia. And the ring intervening these light rays and refracting them distributes them evenly on the nasal periphery. On ASOCT, we can see that the ring rests on the anterior capsule and generally leaves some space between the posterior iris epithelium and the ring. However, even if it touches the iris, it is designed of an hydrophilic hybrid material, which is compatible to be placed in the sulcus. So we did a clinical study in two groups. The therapeutic group basically underwent a second procedure to implant the ring because the patients were suffering from negative dysphotopsia and wanted it treated. While in the preventive group, patients who were suffering from negative dysphotopsia in one eye while undergoing phacoemulsification in the other eye opted to have the ring implanted with the IOL itself. So in all our cases, we found that there was complete resolution of negative dysphotopsia in the immediate post-op period, or negative dysphotopsia did not occur in the prophylactic group at all. How has it impacted the practice? So does negative dysphotopsia really impact the patient's life and the surgeon's life? Well, in the times of promising eagle vision from near to distance, managing negative dysphotopsia with hacks is ironical. There is a burden of 6 lakh new patients of negative dysphotopsia adding to the world every year. And ultimately, it is an iatrogenic effect. So when a patient comes in hope of a solution for vision and ends up having another nagging complication in exchange, the surgeon is always in a soup. We tend to avoid our patients of negative dysphotopsia generally because either we get tired or they get tired of complaining of negative dysphotopsia. My aim is to have a reliable solution so that the surgeon can be confident in offering the solution for a patient of negative dysphotopsia. How does it impact a patient's quality of life? I am showing this testimonial of a patient only to show how it changed his life. And this is the story of 20 other patients that I have recorded patient interviews of.
दिखाई देने में आपको दिक्कत नहीं थी, तो ये चाला सा या वो जो आप कहते हो वो क्या दिखता है? वो दाई से मतलब आप चुनाव आया, चुनाव आने के बाद जो है आप जो है चाला सा हो गया। अच्छा, और आपने हाल क्या जैसे ऑपरेशन के बाद होना था, तो 3 महीने में वो वैसा का वैसे ही बसेगा, तो उससे आपको अपनी आम जिंदगी में काफी अड़चन की दिक्कत थी, दोबारा बैठे थे, तो हमने उसे से बोला था वैसे काम नहीं होता। जब हमने ये उस दिन ये काम किया आपका की हटाई की, तब आपसे पूछा था, तब भी आपको महसूस नहीं हो रहा था।
So this patient was very categorical in telling us that he was able to read and do his bookkeeping at his shop all well. But the problem was that that nagging shadow would always have be in the back of his mind and would always nag him. And he was so concerned with it that at 3 months, he wanted it to be treated and he underwent ND-ring implantation. So I would urge all my fellow surgeons, because we are going to be operating on the millennials and Gen Z, and they are not going to take anything for a compromise. So we have to strive for 6 by SMILE in every case. Thank you.
So the question I wanted to ask you is wonderful presentation, Prakyat, that now this is made by Care Group, right?
Yes, sir.
If somebody wants to use it, they ask Care Group and they're able to supply it to them?
Yes, sir. It's freely available with Care Group. Their sales team, their ground team will provide it to any surgeon who wants to use it.
What material did you say it is made of?
So it's made of the same material with which we make phakic lenses. It is basically hybrid hydrophilic acrylic with a collagen polymer in it.
And it has to be used with the same injector as an IOL injector.
Sir, the cartridge and the injector is provided. It is a disposable injector. It comes in the pack.
Perfect. Anybody has any questions to Prakyat? Dr. Grover, sir?
Really good work. So I think if it offers a consistent solution, it would do wonders. And of course, it will be validated in much larger series, and then it could become a much more universally used thing in the management, at least, if not for prophylaxis. Prophylaxis primarily, at least for the second eyes of those who have a negative dysphotopsia. So really good work. Really appreciate the work.
Thank you, Prakyat. I think you have a live surgery to go. All the
I
best.
would like your permission to
keep shining. All the best.
Thank you so much, sir.
And my next speaker is a colleague and a very good innovator, Dr. Pooja Kamar. She is the phacorefractive surgeon and also involves herself in a lot of clinical and optical and molecular research. Also a scientist at the Grow Lab and I think she's going to speak on next gen imaging, a reality. Dr. Pooja.
Thank you, Rohit sir. And at the outset, I would like to thank Namrata ma'am, DOS team, and Grover sir for giving me this opportunity to present our work here. I have no financial interests in the technology which I'm going to be showcasing here. So these are I'll start with two cases. These are the two siblings which came to our clinic and they were seeking to have just to know whether they are healthy and whether in future they can have a refractive surgery or not. So this was the brother, the female patient who was this thing, and she had a query scissors reflex, and the male patient did not have anything, and this was no cylinder power. Slit lamp examination was within normal limits, and everything was fine. So when we went ahead and looked at the topography, the brother who had a scissors reflex had a suspicious badly, but topography was a little bit suspicious inferiorly, but the biomechanics was normal. However, the female patient who had an extremely no complaints, no cylinder power, topography looked healthy. We were surprised to see that her biomechanics was on the suspicious end. So we kept wondering that the brother who had the scissors reflex had a stronger biomechanics, which was not matching our findings, and the sister who was completely fine had a suspicious biomechanics. So in future, if we have to do refractive surgery for them, how do we go about it? Two normal looking topographies, but the indices and relatively a normal pachymetry, but the indices are not telling us what we should do. So the question was that what are the real meaning of these indices and how do we go about it? And why is the girl with a healthy topography having a suspicious biomechanics and the boy having a query scissors reflex and a suspicious topography have a normal biomechanics? So this is just two patients which I showed, but there are a lot of dilemmas happening in the refractive surgery, as a lot of us come across a lot of these patients. 80% of the patients are going to be normal, straightforward. You can go ahead and do any refractive surgery you want. But then there are cases where we actually keep wondering whether the topography is telling you the actual truth, the topography and the biomechanics. Then there are a lot of thin corneas, absolutely normal looking topography, not very steep corneas, but we wonder whether they are normal or they are diseased. A lot of debate happens whether, a smile is a superior procedure or not, or whether LASIK is still the gold standard, or biomechanically, which is a better procedure. Then came the extra procedure saying if you do a PRK extra or a smile extra in suspicious topographies or borderline topographies and borderline biomechanics is going to be a useful tool. But however, the literature still shows that there is a lot of mystery going around the same. Then decoding the cross-linking outcomes is also sometimes a challenge in a 20% of your cohort. And we still don't know what is the impact of collagen on SIA. So when we do a refractive surgery, this SIA is in cataract surgery, and nowadays a lot of us have started seeing this in a refractive surgery also. So this all are the dilemma which we come across in our daily practice. So how do we solve it? The question was, we need to understand how the corneal collagen looks like. But how do we, why do we need to understand the corneal collagen? The corneal collagen forms the 80% of your, in the stroma, 80% of your structures are your collagen. And it's just not one type of collagen. There are different type of collagens present in your cornea, in your stroma, and also there are fibrils present. So it's not just the density, but it's how the orientation of it also happens, and how the the fibrils and each of them are oriented. So that is how it is important to study the collagen. And it's, as I said before, it is not just about the density, it is also, or it's not about the numbers, it is about the health of your collagen also, which will impact your disease. If you can see these two pictures here, this is done on by the ultrastructure analysis by Keith Meek et al. If you see here, the control groups are not very very nearly situated, but they are dense. Like if you can see, the density is good. However, in keratoconus, they have started becoming thinner and they are very closely attached. So the idea here is not just the quantity, but it is about the quality of your collagen as well, which needs to be understood while you're doing a refractive surgery and decoding the outcomes. So the question here was, how do we study the real-time collagen structure? Because there are ways. Yes, you can take your corneal buttons or your cadaveric eyes and study the collagen structure of the eye, but it is not practical to do it in our patients every day. So how do we do it? So then we came across this group, as I mentioned, Keith Meek et al. And others, Christopher et al., who have been working in Vienna. So we collaborated with them and we built our, with the Medical University of Vienna, and we built our own polarization sensitive OCT. Now, what is this polarization sensitive OCT? Polarization sensitive OCT is nothing but it throws the polarized light on a structure. Here it is the cornea. Now, all your structures take up this polarized light, but the stroma doesn't take up the polarized light. So we take the advantage of it and we study how the collagen orientation and the density of this are in the stroma. So this is how we used this polarization sensitive OCT along with the team of Vienna. And we started this journey in June 2019 to see how it correlates with your topography, tomography, and the biomechanics. So this is how your normal looks like. This is how your theoretical orientation of collagen bundles it's like in your right eye and the left eye. And these are your PSOCT images of the same. If you can see here, like the blue color means the densely adherent collagen. And if you can have little bit of gray spaces, you can see is like those are the places where your collagen bundles are thinned out or they're not present. So this shows that how nicely in a normal eye with a normal topography and a normal biomechanics the collagen orientations are. And these are the normal right and left eye, because the orientation is different in your right and left eye, like your two different hands. So let's see 3 examples. This is how your normal eye is with normal biomechanics and Baddeley values, your suspicious FFKC eyes, and your keratoconic eyes. If you see here, the normal eyes I already described, but in an FFKC eye, there has already been little bit of loss of collagen in the periphery. You can see some green and yellow areas and some skipped areas which are seen here in gray, which means that towards the periphery, the collagen is not present. And this is a keratoconic image, a classic keratoconic eye where you can hardly see any collagen fibers or anything present, meaning that, this is how your, you see the collagen bundles. However, we faced a lot of challenge here when we started showing these cases to our fellow clinicians. For our clinicians, it's very important to decode it very easily. So the challenge here was they didn't connect to it because the coloring system, color coding system and all was not like how you see in your topographies. So our team next went and developed this tool where they we got the images like our corneal topographies. Just to simplify here, the more blue, the denser the blue here in your maps, it means that there are more collagen bundles and the fibers present. And as you go towards the lighter blue shades and the green and the yellow and the reds, it means that there is loss of collagens, or the collagen fibers are not very nicely attached to each other. So this is the same. These are the 3 same cases of normal FFKC and keratoconic, how it looks like. You can see a lot of dense blue color here, and you can see that towards the FFKC and keratoconus, you can see more of light blue colors, yellow or green, and towards the periphery in keratoconus, you've started seeing this red color. So this is how we evolved in our practice with this tool. Now let's come to clinical applications. I discussed that there are 6 major dilemmas when it comes to refractive surgery. So let's address one of them slowly. topography, whether it's showing the real truth or not. So these are the two patients which we discussed, the brother and sister, one having a normal biomechanics, but other having a suspicious biomechanics. It was very interesting that the one who had a suspicious biomechanics, yes, we saw that, and the suspicious topography, that the collagen, yes, was also a little bit lesser, but the one who had a stronger biomechanics had a denser collagen in presence. So here we just want to say that yes, the biomechanics was telling you the truth. Better the biomechanics, better the collagen in your cornea, and low suspicious the biomechanics, yes, this collagen might be not very healthy in this corneas, and this is how your normal looks like. So the second question was, are all thin cornea diseased? Now let's take this example. This is this normal keratoconus and two thin corneas. Yes, one is a strip cornea, but relatively a normal bow tie pattern, and similar thicknesses in both the eyes. If you see the color-coded maps here, this is how your normal and KC look like, which we discussed. The interesting part was, even though the thickness was similar in both the eyes, the collagen was not same. It was different in both the eyes. If you can see here, the thickness is 485, the collagen bundles were almost like a diseased keratoconic eye, and the thickness, which was 477, it was, if you see here, then the collagens are as good as normals. So this just meant to we mean to say that all the thin corneas are not the same. We need to take each of the thin cornea as separate while decoding them and planning your treatments, because your disease, your thin corneas can be normal or diseased. So we need to customize our treatment based on the same. And for this patient, even a PRK procedure would not be ideal. We would probably go ahead and do an ICL procedure. And here, if your power is lower, you can probably go ahead and do a trans PRK procedure to have a healthy cornea. So this will actually help us in our practice in future to decide our treatment and customize our treatment, because we are going to see a lot of these cases in future where your biomechanics and your topographies are not going to match. So we need a tool like a polarization sensitive OCT to decode what to do actually with them. The second burning, the third burning question, as I said, is SMILE superior? Now, when it came to SMILE came into practice, a lot of them said that it's a smaller cut, so it has to be biomechanically stronger, but it had a lot of dilemma. So this was one of our work, which was a part of my PhD, where we studied the intraop change in biomechanics and the healing post-operatively. Yes, we did see that intraoperatively, when we just created the flap, there was loss in biomechanics. However, there was not much change in biomechanics in the SMILE. But the interesting part here was that at 1 month, both the LASIK and the SMILE procedures behaved equally same. Meaning to say that, yes, the early healing might be better in SMILE, but at 1 month, both the procedures are going to act equally same. So this is this is like breaking the myth that both the procedures are probably the same in a longer future. And this is not just done by a normal biomechanics like CBI, TBI, or other indices which you see on your Corvis. This was done by a lot of analytical modeling associated work, which has been framed by my colleagues, Mr. Matthew and Dr. Abhijit Sinha Roy. So we wanted to see that whether the same findings are applicable for the the wound healing is going to be same at the collagen levels also. So we did the same experiment where we studied intraoperative polarization sensitive OCT to see what was happening to the collagen. We saw similar trends that yes, in intraoperatively LASIK was there was a little bit loss of collagen present, but at 1 month and 1 week, both the procedures were doing equally well, suggesting that at the wound healing level also, they are doing equally fine. Probably one application which we can take from here is that if you want to do an extra procedure, you're going to do it at this point of time. So the extra procedure might work better with SMILE because there is not much loss of biomechanics than at the LASIK, which also helps us in the same. But the mystery was, do extra procedures actually work, or they are just because you're doing a different protocol? So just this were the two this was one patient. We did a contralateral SMILE and SMILE extra eyes. Topography, yes, here the biomechanics was suspicious. That's why, and the polarization sensitive OCT findings matched. We can see here there is somewhat loss of collagen. So based on the polarization sensitive OCT findings, we decided, and the other clinical findings, we decided to go do SMILE for one eye and the SMILE extra for this eye where there was loss of collagen. And to our interest at post-op 6 months, if you can see, the SMILE and the SMILE extra eyes are doing equally well. If you can see here, the collagen is becoming a little bit stronger where there was a loss of collagen. And also it's matching with your biomechanics. This is the SSI scale where you can see the biomechanically also it is becoming a little bit stiffer where we have done an extra procedure compared to the procedure where we have not done an extra. So this is just showing that the extra procedure do work in the places where there is a suspicious finding or there is a loss of collagen on PSOCT, and post-operative results are decent. The third was recoding outcomes. Now, these are the 3 keratoconic eyes, similar grade of KC, similar thicknesses, and we had done the PSOCT, but the PSOCT findings were different for all the 3. Like similar, even though they were similar looking topographies and similar grades, they were the collagen orientation and the density was different between all the 3 eyes. So we went ahead obviously and did the cross-linking procedure, but interestingly what we found was that at post-operative 6 months, this was the flattening which we saw in 3 patients. The patient with a denser collagen had a more amount of flattening of around 14 diopters in the cone area. The patient with a little bit loss of collagen, like better collagen compared to this, I had a little moderate amount of flattening, and the patient who had no like sparse collagen or a very less collagen in the eyes had they didn't progress, but yes, they didn't have a very good flattening as the other 2 patients, and this was the post-operative outcome of this patient. So polarization sensitive OCT, where we can study the collagen, will also help us in decoding that how the outcomes are going to be, how your flattening is going to be, whether you're going to have an optimal or an suboptimal outcome. The last question was to study the impact of collagen on SIA. This is an ongoing work by my colleagues in cataract department. We again, a lot of times there is a myth about how much SIA would be this thing. We have to understand that SIA is not just about how your skills are. SIA is also about your collagen orientation, because if you see here again 2 normal topographies, but the collagen orientation is different in both the eyes. One has a good amount of collagen, the other has sparse collagen. And if you see when we did the cataract surgery post-operatively, the patients with good collagen had good quality of vision compared to the patients who had sparse collagen, because they had induced astigmatism, not because of surgery or wrong calculation of your toric IOL power, but it was because of the collagen orientation and the collagen fibers in your cornea. So this were but the question here was, are we seeing the real truth? What we are seeing in the PSOCT findings, how do we know that those are true? And like, is this enough? So what our group has done a lot of work, and a lot of you know about it, on tears epithelium in keratoconic eyes, where they've studied the LOX and collagen levels in this keratoconic eyes with different grades, and they've seen that with higher grades of keratoconus, the LOX and collagen levels start reducing. So we wanted to study the same thing here, and we wanted to correlate the clinical and the PSOCT findings with the molecular findings. So we designed the study.
You sum it up quickly, please. Already ahead of time.
So we just took the SMILE lenticules and the epithelium of the patients who have undergoing the surgery, and we did the gene expression analysis. This was the patient who had steep cornea, biomechanics was suspicious. Intraoperatively, we collected the epithelium after doing a trans-PRK from the periphery, and the PSOCT findings also showed that there was a little bit of loss of collagen here, and we saw that the LOX and the collagen findings also matched. LOX was borderline, and even there was less collagen compared to controls. So it was matching. Our PSOCT findings were matching with the loss of collagen and the suspicious biomechanics. So just to summarize, the future would be we are working on this AI-based software where we are trying to club all the data from the Pentacam, the Corvis, the epithelial mapping, and PSOCT, and actually predict the outcomes of the surgery. Before surgery itself, you can predict the outcomes of what it is going to be, whether you're going to have a suboptimal outcome or an optimal outcome. And it has a lot of applications, not just in the ones I mentioned, but you can also have applications in retinal disorders, macular disorders, optic nerve imaging, and etc. Thank you.
Any questions from the panel? Dr. Grover, would you like to ask anything?
Amazing work. I think this is going to demystify a lot about the propensity to ectasia. And I think this is going to add a lot to what our planning for our refractive surgery procedures, as well as the predictability of the CXL. So I think really a fantastic work, mind-blowing work. So PSOCT will be a very useful tool in establishing all that we had suspected or thought about. So really great work, Dr. Rohit and Dr. Pooja.
Dr. John, do you like to add anything, or anybody in this group?
This is very interesting work, and in fact, I was impressed that the SIA work has also been started. So we always thought that SIA is just a precise calculation of how we make the incisions, but now you have shown us that the corneal collagen is something which we have been missing. So once we know that, also that completes the equation. So I think that is going to be a phenomenal work coming up.
There was always this data which showed that the SIA varied from 0.05 to somewhere around 0.6, even with the same 2.2 incision, and there was no explanation for it. So we may today have an application, something to explain why that happens. There was a very large skew in that data, and that was not explainable. We always had a mean figure to put in our calculations, but never an explanation for why there was such a wide variation.
And this is just not for the, this is just not the corneal application. The application goes beyond cornea. It's got a huge application to retina. I think Tirumalesh and his team will probably work on that later. But ability to look at the cellular details at a much better resolution is amazing. Dr. Amar, anything you want to add before we move to the next speaker?
No, I have less expertise in this one. I would want to add a sentence to it. Basically, when they did image retinitis pigmentosa and degenerative retinal disorders, there was a higher resolution that we could image the retina with. That's one. And second thing is the polarization gradient which was there was able to pick up the degenerated layers a little more accurately than the normal OCT. But although we need to look into it to actually come out with prognostic or pointing markers.
Thank you, Tirumalesh, and thank you, Pooja. We move on to one more very nice innovator, and we've been hearing a lot about his work, imaging, Dr. John Davis from Arvind, and he would speak about his innovation for today. Dr. John, all yours.
Thank you, sir. I would like to, at the utmost, I would like to thank DOS, Dr. Namrata ma'am, Dr. Rohit Shetty sir, Dr. Grover sir for this opportunity. I'll be presenting on something different. So this is not from the lab to the clinics. This is from the kitchen to the clinics. Is my screen visible, sir?
Absolutely, perfect.
Okay, sir. The kitchen ophthalmic surgeon. This is Dr. John Davis Sakara, and these are my co-authors. The authors have no financial interest in this presentation. Women doctors may find it especially hard to juggle their career and family life. They face intense competition at work for few successes. They often have to work extra hard to get ahead in this world. In addition to all, brought a lot of surprises. The coronavirus attacked humanity. It rapidly spread across all the countries of the world. The world had to go into a lockdown. Elective surgeries reduced drastically and surgical training practically stopped. Practicing in the wet lab became even more important. Many surgical trainees were stuck at home and resorted to hobbies like cooking. To make the best use of this time, we cooked up an idea. Why not convert the kitchen into a wet lab? Let's take the ingredients: flour, oil, salt, water, tomato, boiled egg, grapes. Do we need the fork and spoon? No. We need surgical instruments. Welcome to Anju's kitchen. Mix flour in the bowl with salt, oil and water. Then knead the dough till it becomes the correct consistency. Sometimes the baby might want to help. Now let us multitask. Fire up the stove, put the water on and boil an egg. Now again take the dough and knead it into the shape of a face. Make eye sockets and nose and mouth. Remove the shell of the boiled egg and then cut it into 2 pieces and use that as the sclera of the eyeball. Put it under the face made of dough. Then cut grapes to put as corneas. Watch out for the baby taking the food while you are making this. You can practice local anesthesia with syringe and needle. You can simulate the feel of a microscope by putting a smartphone between 2 boxes with the video mode and flash on. This gives magnification, illumination and allows you to record your surgeries. A tomato with needle and thread can be used to practice superior rectus bridal sutures. SICS tunnel can be practiced on the boiled egg using a crescent blade, even a side port, and also a keratometry. If you have a magnifying loupe, you can use that instead of the smartphone microscope. Make a cystitome by bending a 26 gauge needle. You can practice capsulorhexis on the skin of a tomato which has been kept in the microwave for 5 to 10 seconds. You can also use that smartphone microscope simulator and an onion. Similarly, you can also do a can opener capsulotomy. Nucleus delivery can be practiced with metal wire to take out a seed or garlic, for example. If Simcoe is not available, a syringe can be connected to a tube and pick up tissue paper bits from a bowl. It would definitely be better to practice irrigation aspiration with a Simcoe cannula. Bits of tissue paper can be aspirated from any bowl. For phacoemulsification, a piece of potato can be cut out. This can be cut in the shape of a cataract nucleus and using a pencil and needle can be chopped. If available, loading of foldable IOLs can be practiced. Along with the proper injection of the IOLs. Other than cataract, trabeculectomy flap can also be practiced on the boiled egg. The incisions can be made and the flap can be raised. A cut grapes fixed on a toy can be used to practice suturing. Tomato can also be used for suturing practice. You can use building blocks as a corneal trephine and then use corneal scissors to cut out a circular bit of the tomato skin. This can then be transplanted onto some other fruit to practice corneal transplantation sutures. Cut out a circle of tomato skin and make a hole in the center to use as an iris. Thread a suture material through the sharp end of a needle so that it comes out of the hub. Let us do sewing machine technique of hydrodialysis repair. Pass the needle with thread through the tomato and tissue paper, hold the thread, come out and pass it again through the tomato and tissue paper, and this time hold that loop of suture material while coming out. Once again, go to the next point where you want to have the suture, pass the needle through the tomato and the tissue paper, and once again hold the loop of suture while coming out so that you get the next loop. Once you have had adequate loops, you can take the thread and pass it through all the previous loops and then tie it. Now let us practice single pass 4-throw pupilloplasty. The straight needle is passed through two sides of the torn iris, and then a Sinskey hook is used to pull out a loop of suture from the distal side. Then the needle is passed 4 times through this loop of suture material. Those are the 4 passes. And then both ends of the suture are pulled apart and the knot slides inside as a sliding seepser knot. The two ends of the suture can be cut with a micro scissors inside the eye. Thank you all for watching. Hope this guides you to set up a wet lab in your kitchen and practice eye surgeries at home during this pandemic. Thank you.
Wonderful, John. I think we have heard a lot about your scene and a lot about your other innovation, but this was very good. I particularly like the 4-throw pupilloplasty, what you demonstrated, and you missed the SFIR.
I should do that, sir. So this is all born out of necessity. My wife had completed her post-graduation and she couldn't join the fellowship. So she was sitting at home and she said, I'm at the kitchen, I should be operating. So I brought the operating theater to the kitchen.
Fantastic, fantastic. I think if you can design an innovative small cameras which can be used, microscope, simple microscope which can be used, that's what I think Rohan is going to show also. Using some phones, you can probably have a lot of students practicing these things under the feel of a microscope. I think like all of you are innovators in imaging technologies. I think one thing we should need to bring out is a simple home-based microscope for because that is the need now.
Yes, sir. Right now, with just a single smartphone, we are losing stereopsis. Yes. So I want 3D. So as Dr. Raju would tell, 3D is very important. So I will make a 3D microscope which can be used at home.
It should be not so costly. It should be used by students who go home. See, it's impossible to all the time go to the wet lab. Suddenly you may get a feel of, say, in the midnight, if you're insomniac and you want to go and practice, then you can't go to the wet lab. You should think about some innovation where you should bring a simple microscope. Like, for example, when we are doing MBBS, everybody in the first year had to buy a bone set, your skeleton set. So because it's at home, you're going to, imagine if you had a bone set in the hospital, how many of us would go into the room and check? So I think the next innovation you guys should do is to bring a simple model of thing to the clinic. I think Rohan has some idea about it, but you should probably try to bring this to the reality. Dr. Grover, yes, sir. Namrata ma'am, you are here.
Superb work. I think these innovators are making us proud. And great to have Namrata, who's made this session possible. Namrata, your comments.
I think I was just watching very innovative grapes used for suturing, and then for your proline suture with a single thing again used, an egg wing used for trabeculectomy. I mean, it is really amazing the way you've thought about it. But what I think Rohit is saying makes a lot of sense, that you should come out with model. It could be plastic, it could be any material that you think, it could be Teflon, and then patent it. I think, Rohit, that is what you mean to say, like, that you have your bone set when you come to the anatomy. So people should buy this before actually they even go to the wet lab.
The microscope also.
Yeah. So this should be stage 1, then stage 2 will be goat size, and then stage 3 would be, your. So you could have a microscope, which is just maybe just with the 2 binoculars, not a very.
Yes, ma'am. Can be done, ma'am.
But John, I'm sure where John hai to mumkin hai, huh? Sab kuch to wherever John is there, he will make it happen.
Yes, ma'am. Thank you, ma'am.
Thank you. Thank you.
Really Wonderful work by all these innovators. It's been a revelation attending this session.
I think we will, Rohit, if you allow, we will send this session as a separate session on email and on, of course, your YouTube Live and Facebook Live. It's already there, but we'll send it as a separate this thing from DOS platform. And if you allow, we can send it from AIOS platform also.
Please.
Thank you.
Great.
I think Rohan is going to take a small lead from what John said. He made a kind of a home-based camera to do this work. Rohan is now busy with cataract refractive surgeon in Uttar Pradesh, Sohanpur, with his parents. Very innovative guy, and he did some good work with our team to build this camera. I think that's what you're doing to show, Rohan, or something
Yes,
else.
Yes.
Okay.
I'm going to be showing the Miyake Apple camera modification of that. Yes.
All you, Rohan.
Thank you so much, sir. At the very outset, I'd like to thank DOS for this platform, and I'd like to thank Dr. Rohit sir for giving me this opportunity here, and team Narayan Netralaya for giving this opportunity to actually build this innovation that I'm going to be showing. Is my screen visible?
Perfect. All good. Go ahead.
Yeah. So this modified Miyake Apple technique for posterior photography and video analysis of cadaveric eyes is what I'm going to be presenting. So as a postgraduate student, we are always in the dilemma, where theory or practical, we all get the theoretical knowledge from the books. And especially now in COVID times, the practical part is lagging. So we're always confused. When I was in post-graduation, at that time, I came across this paper for the Miyake Apple study of the rotational stability of Acrisoft toric intraocular lens after experimental eye trauma. So what the method they used there was that 2 human cadaveric eyes were prepared in accordance with the Miyake Apple technique with closed system modifications. Now, that got me thinking that could we also try this Apple Miyake technique and not just restrict it for just a few things, but actually go ahead and use it in all endeavors in ophthalmology. So this was the Miyake Apple camera that they used. And as we can see, it had a microscope on top, then a platform where you would put the cadaveric eye and a microscope at the bottom as well. This was a expensive proposition. So it was also impractical because it occupied a lot of space. Space is a constraint nowadays. And it was fixed and it required a lot of biomechanical expertise. So, when I joined Narayan Netralaya, I still had that idea, and thankful to Narayan Netralaya that they take in so much of our ideas and actually pay heed to what we are saying and, allow us to innovate freely at all levels. Then I went and saw all the latest advances that were happening in Narayan Netralaya, and, from the femto platforms, right, to complex surgeries, all these things were performed. But then when I pitched this idea of doing this modification on the Miyake Apple platform, it was well accepted. In the era of smartphones, the use of smartphones in the field of ophthalmology has exponentially increased in the last 5 years. So I wanted to use this smartphone into this and incorporate into this Miyake Apple technique. So the aim of the innovation was to describe a modification in the Miyake Apple posterior video analysis for the visualization of the anterior posterior segments during wet lab based training efforts. So this is the model that we created, extremely simple, extremely economical and portable. So as we can see, it has a mounting platform. On top of that, we have this transparent experiment cover. Then a phone mount is there, and a XY axis rotational is also there, so that you don't have to keep touching your phone. Just rotating the knob, you'll be able to get good focus of the work that you're doing on the camera. It has a transparent sliding cover, so you place the phone once on it, and then you just slide the cover back on, and that's all that is needed to be done. So this is the top viewing microscope. So if you see from the previous slide, from the original Miyake Apple, you had a microscope on top and a microscope at the bottom, which increased the cost a lot and made it a fixed platform. What we've done here is we have a microscope on top. You can place this model onto any flat top table, and all you need to do is place a camera underneath. So what is the other thing that, again, first what we thought was we'll just use the phone camera and try and focus it. So initially it was all hit and try, and the focus wasn't coming even with the latest and the most expensive of cameras on the phones that are available these days. So simply putting a 10 diopter PMMA lens on the camera of the phone helped us tremendously in focusing. And of course the XY adjustments made sure that the phone was stable, and it took the autofocus once, and that autofocus was there throughout the procedure. So this is how the phone is mirrored onto the laptop. Once the phone is placed on the camera, you can easily mirror it onto the laptop via the wireless transmission that is there via Bluetooth, or there are many mirroring apps that are there thanks to technology. So no wires are required, completely wire free. So the next question is cost. So that is a huge thing in this, that it is so cost effective and the benefits are huge. So this entire standard solid breadboard is for about 5,000 rupees. The XY compartment was for 20. The PMMA lens, as we know, cost rupees 100. The glue to fix the eye onto the platform was for 300. So the total cost was less than 25,000 rupees to build this entire set. So it's extremely cost effective. It can be built, it can be moved around, and it gives amazing photographs and videos, as I'll be showing you in the slides ahead. So the benefits, of course, it's pocket friendly. Teaching modules in wet labs, it really helps in understanding anatomy, especially at the residency level in the first year. It gives a wholesome understanding of complex procedures. Corneal procedures can be done. So as I said, mostly what we had seen was it was used in only one or two aspects. But here, using this phone, we have made sure that it can be used in multiple procedures, like the corneal procedures of bubble dissection, suturing, then SFIOL, glaucoma. Also, we used it in the transcleral cyclophotocoagulation of ciliary processes, and of course in the retina also, in phakic eye position, angulation, and vitrectomy, understanding how vitrectomy occurs. So how was our experience? We got cadaveric eyes thanks to the eye bank that we had in Narayan Netralaya. We cut them open, and once they were cut open, they were carefully dissected. You can see how nicely they've been dissected. We can actually see the optic disc and the macula on the retina. Then once they were sliced, we placed trocar cannulas in it for procedures, and if we needed lighting underneath. So this is a still photograph. We can see how, from the pars plana at 4 millimeters, inserting a trocar cannula is seen from the other side. So as they say, from the dark side, the side that is not visible at all in, of course, the living. In the cadaveric eye, we can use that for understanding anatomy extremely well. So this is the bubble dissection that we did on a corneal button. We'll see just now how beautifully we can capture it from the other side as well, which gives us an amazing idea when we get a simultaneous view from top as well as from the bottom. The transcleral cyclophotocoagulation in glaucoma patients, we can again see that cytocoagulation is happening from the other end, and we can see it from this side. And the photograph that we captured, we can see the destruction of the ciliary body very beautifully captured from the other side. Now, shaving off the strands of the vitreous near the ora serrata, this also is a beautiful video that has been taken. We can see how the tugging is happening on the retina when we are doing a vitrectomy. Light source was used, and we can see how the vitrectomy cutter, understanding what are the limits when we are doing a vitrectomy in a case of retina vitrectomy or core vitrectomy when we are doing that. Fixating and positioning, again, for the SFIOL, the clasping of the SFIOL and bringing it out on the other side. We can see the IOL coming into position. We need to make sure that it is centered. So exactly how the IOL, in which direction when we pull it, it becomes centered is seen from the Miyake Apple view. The exit of the haptic was again documented on a still photograph. So we had a fair share of complications also that you could learn from. So in this case, we'll be able to see a very beautiful, I shouldn't be saying beautiful, but of course it's part of the procedures, a ciliary detachment that was occurred because of forceful entry that had happened when we were trying to do, the pulling of the haptic. We'll be able to see the ciliary process getting, actually the ciliary body getting detached from the zone There, if you see on the top right, the ciliary body is getting detached. So not just doing the procedures right, as we have learned throughout residency, it's very important to know when the complications occur as well. So what we know is that the Miyake-Apple technique for the imaging has been in use for 2 decades to image various wet lab-based procedures. Till now, 2 microscopes were used for imaging, which made the setup space-consuming, fixed, and very costly. What the innovation adds is that it reduces the cost of the setup by many folds, making it extremely affordable and increasing our outreach for learning 3-dimensionally. Our innovation is also portable and can be easily moved from one platform to another. So translational potential, our model can be easily built and used for teaching purposes of postgraduates for better understanding of the subject. Not just postgraduates, it can also help established surgeons for exactly visualizing the posterior view of many blind procedures that we do and perform to make them better to enhanced understanding. We have been hit by the COVID-19 pandemic, and we know that as trainees and as residents, our training has been hit. So this really can be helpful. And, you know, after 9 months of absolutely no training in the pandemic, thinking out of the box and thinking more will help us in achieving these innovations and coming up with ideas which are extremely affordable as well. I would like to end that necessity is the mother of invention, as we can see here. And I hope that this innovation can be taken forward, and it can, because it is extremely affordable, be used at an individual level by everybody, if not even at the institute level. Thank you so much.
Thank you, Rohan. You can stop sharing the screen. I open this to discussion. Dr. Grover sir, Namrata ma'am.
Wonderful work. I think the support that they are getting for their ideas from the institution is mind-blowing. I think that is really helping them blossom into innovators. And the opportunities for understanding of a lot of things which we do blindly, including the vitreous procedures, including the sulcus fixations, and all those, the applications can be mind-blowing. I think the limiting factor why it was not being used much more often was the cost and having a setup like this. So these innovations really open up the opportunities for all the institutions to build it up. So I think once you get a patent and make it commercially available, Rohan, that will be a really good help to Indian ophthalmology and the world ophthalmology.
I think it was really breathtaking, you know, because these Miyake views, Miyake pictures, we've been seeing in the various journals, and we know that labs, David Apple's lab has been, you know, working on it since our PG days. That's what we've been seeing. And this completely seemed out of leaps and, I mean, out of our reach. And, you know, you made it possible that everyone can have it now. I mean, it's unbelievable. So I think what sir is saying is very right, that we have to give, you know, credit to the institution which is allowing these things to, these things to happen, giving opportunities, allowing their minds to, you know, of course, all the youngsters, they are very bright, they are very fast, and they have, you know, they think much ahead, and the technology is so good that when we can't catch up with the technology, they are far ahead on it. So I think kudos to Rohit Shetty, Narayan Nitrale, Rohan Mehra, and all the innovators here for that matter, you know, who are able to take it forward. You're really, really fortunate to be able to do it. It doesn't happen everywhere, and it doesn't happen at all the times.
And what I would like to say is DOS-like platform, innovation platforms are not platform just to present and go. Like this is what I mentioned, Raju Sambangi is not here. I was the moderator or something many years back in Bangalore, and then it translated into a product. And I've seen John talking about it in many platforms. I've seen Amar speaking about the OCT base or Prakyat. What I'm seeing is a lot of these youngsters, ma'am and sir, are bringing that thing to reality much faster than what we used to see many years back. And now for Prakyas, already it's available. You can go and buy it from IOCare, and that is the real innovation. And I think that is something which I think is the beauty of present day innovation. And that's, I think, what the innovation, what you've done like IAIOS or DOS, giving this platform for youngsters to come and show, makes everybody start thinking, okay, I can do something. I'm sure Rohan and Amar and John would be already thinking, how do I bring in? Because I was thinking about that microscopes. A lot of people have depth perception issues. If you bring in a microscope, they can go home and practice every day and using your cell phones or whatever, like how Rohan said. Thank you, Rohan, and thank you, sir and ma'am. Let's move on to the next speaker. Divyakant is here.
I would only say that AIOS and DOS should have an institutionalized mechanism to help these innovators. These talks have been really wonderful from talk one. It should be preserved for posterity, presented to a lot more people. And the AIOS should come up with a program to help these youngsters file patents and carry on with their process. I think we should get involved as AIOS, as DOS, to help them in going ahead with their innovations being patented, so that it becomes useful for everyone.
Ma'am, even though this is not a platform to discuss, I think during your tenure, you should bring in a patent lawyer and a patent office in AIOS, so that people who don't know where to patent, the AIOS should facilitate, and AIOS should probably pay for this patent lawyers daily, whatever thing. I mean, if it's a money involved, then the person can pay. But if you have a patent office, a lot of these young people can directly apply through that, and it'll be much more streamlined. I'm not sure whether we have it, but I think you should bring this up.
We don't have it, but as of now, what we plan to do is that we plan to do a focus group meeting for the patent thing, and we have Dr. Velu Pandian, who is at RP Center and knows a lot about patenting, and his wife is a patent lawyer. So I was just talking to them, and we are going to, make it happen. That this is the next step.
Thank you.
Thank you.
Can we have Dr. Divyakant Mishra?
I think Divyakant has not joined.
So then we have Dr.
It's 12 o'clock.
Then we have Tirumalesh ready with this presentation.
I'm ready, sir. So I'll go next.
Yeah, Dr. Tirumalesh, a very good friend and extremely good surgeon when I met him. I mean, still a good surgeon. But I always used to say, you are a thinking mind. You have to also do some amount of innovative research. He said, my hands move faster than my mind. I'm skilled. I'm super skilled. I know, we all know. But I'm very fortunate that I've realized that he's much, much smarter thinking than his hands can do. I mean, his skills are, I call it the secondary now. His thinking is primary. And you'll see wonderful innovation with animals, and work with a lot of new drugs. I mean, his work is real cutting edge, and we'll see some exciting. But this is all what he's done. He still goes to the animal labs, and he injects those stuffs, and gives some torture them. But still, it's for the science.
No, but Rohit, I'm really happy that you could get this out of Tirumalesh, because I never imagined when Tirumalesh was in RP Center that he would ever get into, research, because he is an inquisitive mind. He'll ask a lot of questions, but he will not look for answers. But I'm so happy now that he's started doing it. So actually it needs, mentoring from people like you to get the best out of everybody.
Now in fact, I've coaxed him that he's going to be my next year's first PhD student of 2021.
Wow.
So, but when he joined, he would just say, sir, I don't, but this is what I want anybody who's listening to understand, that God has not made you to be in one mode. You are multimodal. And we have assumed that we are only one mode. I'm a good surgeon, I can't do research. Or I'm a good researcher, I can't do science. Namrata ma'am is a classic example of this. Grover sir is a classic. They are multimodal. They can do multi things at multiple times. And I think, Tirumalesh, let's see your beautiful innovation, something which is going to be your part of your PhD.
Yeah. Thank you, sir. The animal experiments, I think we still wanted to hold back because Arka said there are few issues with the patent. So what I'll be presenting is what we understood with reference to the choroidal neovascular membranes and its new pathology, and with reference to what we are working. So I'll share my screen, and
Please
I
do.
hope my screen is visible.
Not yet. Yeah, you have to enlarge that. No, it's
Okay.
still.
The
simulation is still in the now. Yeah.
Thank you, Rohit sir, for those very kind words, and thank you, Dr. Namrata, for remembering my old days. And it's still Dr. Rohit is pushing me for all these innovations, and I really thank him for being the mentor at Narayan Nethralaya. I thank you all for giving me this opportunity. So what I will be presenting today is why are CNVMs difficult to treat, and why should we be persistent in that treatment? So if you look at this slide, the pathophysiology of AMD is extremely complex. There are too many pathways which are involved. But what we have is one drug which targets the anti-VEGF pathway alone. So when there was this survey which was done by the ASARS, which was the Preference and Trend Survey in 2018, many of us retina specialists felt that there should be a drug which should have an improved efficiency, there should be a reduced treatment burden, and there should be improved safety, long-term sustained delivery agents, and newer treatment for the mechanism of actions which were involved. So based on this, look forward, many people are working on it. And if you also look at a real-world scenario, you would know that many of us who are treating also know that many patients would not come in and take 3 loading doses as it is mentioned, and it does make a lot of difference in the long-term outcomes. So these are the 2 questions which we are trying to answer. One is that where do we really give loading dose, and how does the aqueous humor profile factor and comparisons of them with the OCT help us in making a decision of giving a loading dose, or which would require longer treatments and who would require prolonged treatment intervals. So our study today is will be dealing on this particular thing. It will deal with association between the aqueous humor profile levels and the edema resolution. So how we did that was that we did an OCT measurement of the edema volume between 2 visits, and we also took aqueous humor and the soluble factors, and we tried to correlate between the 2. So the design or the method was that in visit A, we did OCT, we gave the patient an intravitreal injection, and we collected an aqueous sample at the time. And at visit B, the OCT based imaging was done and the edema was measured, and difference in edema volume was correlated, and we looked out for the results. And we also did a soluble factor measurement using multiplex ELISA based measurements of the soluble factors in the aqueous humor which was collected. So as we all know, this is a type 1 kind of a CNVM which we included, and these were our type 2 kind of CNVMs which we included. So what we called optimal response in the stats that we are going to see is something like this. If you have a fluid like this and a shrum, and we gave an injection, and when the patient came the next visit and we saw this was the picture, we call this as a suboptimal response because there is some amount of persisting fluid which is still there. So when the patient came to us back like this, where there was not much fluid, this is what we called as optimal response, and this is what we would want to see whenever we give an injection. So how did we come to this conclusion of optimal and suboptimal? Was that we took 25 B scans which were taken on the central macula. The edema area was calculated at each frame, and the area calculated was integrated to get volume, the edema volume, and edema volume pre and post injections were compared, and that gave us a stat or a numeric based on which we made a calculation. So basically we did a differentiation of the image so as to find the area where there was fluid, and then we did an integral calculus to identify it or put it together to do the calculation at a later part. So this is an important slide which kind of changes our understanding with reference to how we understand choroidal neovascular membranes. If you look at the top part, we all know that there are the CNVM follows the classic angiogenic pathway, and hence VEGF is no surprise. When compared to controls, aqueous samples which were drawn from patients who underwent cataract surgery, we saw that patients who are having choroidal neovascular membranes had aqueous levels of VEGF which was very high. And if you look at it, the ones which were recurrent had higher levels of aqueous than those compared to the treatment naive group. So this is an important factor which I would like people to look at and think about it, which is angiogenin. So back in the 80s when Judah Folkman was working on the angiogenesis factor. He's the father of the modern angiogenesis pathways. Till then it was known as Michelson's X factor. What Folkman said was that VEGF was one of the most important factor, which was pushing the angiogenesis, or the background which pushes the angiogenesis. However, 3 years later, from the same grant which Stanford had given them, they also found that there is another factor called as angiogenin, the level of which was very, very minute. However, in presence of angiogenin, VEGF works 40 times faster, which means that angiogenin is one which was actually driving VEGF. And because the level of angiogenin detection and the sensitive predictors were not there at that point of time, so angiogenin was not talked about. So the other things that we also found in the aqueous humor of these patients who are having the choroidal neovascular membrane, where there was a huge surge in the interleukins, the IL-1 alpha, interleukin 6, interleukin 8, interleukin 10, interleukin 17F, and interleukin 12 and 23. So what it means is that once there is vascular leakage and there is immune trafficking of cells, so these monocytes, macrophages, and the immune-derived cells tend to accumulate within the retina, and they initiate what is called as a chronic inflammatory process. So how do they kind of recruit more and more cells is by using the so-called chemokines, which is again a driving factor, and which we saw that in patients with choroidal neovascular membrane was very high. And it was also but natural or a no-brainer that the soluble cellular adhesion molecules were also high in patients who are having choroidal neovascular membranes. Now coming to our study, what happened when we kind of looked at in these two visits, and what happened with the correlation is what I'm going to tell you, is that the classical angiogenic factors, when there was an optimal response, there was a very good suppression of both VEGF and angiogenin. However, in the patients who were having a suboptimal response, both VEGF and angiogenin were not suppressed to a great extent. When we looked at the cytokines and chemokines, we also saw that interleukin 1 alpha, interleukin 6, interleukin 8, interleukin 10 was protective, which means that if along with VEGF suppression, there was an elevation of interleukin 10, it was protective. However, all the other interleukins showed a positive correlation. Same thing happened with the chemokines as well, the CXCL3, the CXCL9, the CXCL10, MIPs were all increased, and so were the adhesion molecules. So this gave a positive correlation. Now what we did next was we took these aqueous parameters, and we then plotted graphs and saw how these resolution patterns on the OCT fared when we compared with the aqueous soluble factors. If you look at all the ones which are red, these are the ones which were found to be significant. If you look at it, angiogenin had a positive kind of correlation because the VEGF values were not too fluctuate. But however, the angiogenin values were very, very significant when it came to the correlation. So was IL-10, so was fractalkine and MIP. If you look at the recurrent ones or the suboptimal ones, there was a very positive correlation between the OCT volume changes, the edema volume changes, and the factors which we found in the anterior chamber. So these are the findings that angiogenin was angiogenin, MIG, IP10, fractalkine, MCP, and IL-12/23. The ones apart from angiogenin are all inflammatory mediators, and very, very surprisingly, we found that all these were very high, and they showed a very positive relationship with difference in the edema volume, which also means that when these were high, the resolution was incomplete. Hence, if there is an initial fluid or edema volume, it means that this patient is in for larger number of injections and long-term follow-up. So what is the significance of this? As I told you, angiogenin is an extremely potent pro-angiogenic and powerful angiogenesis mediator. The MIG1 is a monokine-induced interferon gamma, which is associated with angiogenesis and immune escape mechanism. Hence, it promotes angiogenesis in spite of VEGF suppression. The MCP1, which we found, is known to increase the invasiveness of the vascular proliferation, which means that once there is a breakage of the Bruch's membrane, initial invasiveness of the vascular membrane is known through the VEGF, but MCP1, if it is present, will cause the membrane to become more and more large. That is why you see that there might be few patients which have extensive membrane formation, and we positively associated that with MCP1. The IP10 or CXCL10 is a crucial leukocyte trafficking and homing factor, which keeps the immune cells and perpetuates continuous tissue damage and inflammation. Hence, it is something which keeps the chronic inflammation going on. The fructalkine, when present, is an anti-apoptotic mediator, presence of which the endothelial cells which are there in the newly grown membrane, it keeps patent, and hence we see that OCTA kind of shows that even in resolved membranes, that all the vessels which are there are still patent, and it also supports the survival of multiple cell types during the homeostasis and inflammation. Coming to IL-12 and 23, what it does is it causes induction of inflammation and immune adaptive responses, which regulates the local immunity, induces and maintains chronic inflammation. So these are the factors which actually keeps the CNVM continuously active over a period of time, in spite of giving anti-VEGF treatment. So what it also means is that we have to look for alternatives apart from just the anti-VEGF agents to actually suppress this mechanism and make the treatment more effective. So the take-home message is all the above factors show positive relationship. In other words, it showed an inverse relationship with edema resolution. So what it actually means is that whenever there is an initial increased fluid or increased edema volume, those are the patients which will require large number of injections. And combination treatment, as of now, probably what is available is probably a steroid. However, there are a lot of other target molecules which are working in most of the animal models, but we are still validating the results. So that's why I restrained myself from presenting those. So these are a few, our previous work which we presented in IOVS. There is a negative feedback loop which exists between angiogenin and telomerase. We also demonstrated elevated angiogenin levels, which was associated with both forms of age-related macular degeneration, which is regulated by hypoxia and also the telomerase. So in 2017, our chief scientist at GrowLab, Dr. Arka Ghosh, applied for this patent, where we demonstrated positively that angiogenin can be, from the tears and aqueous, can be used as a biomarker and as a predictive agent of how AMD would progress and respond to treatment. This is, the work, what I presented is all the hard work that these people did at the lab, and also from Renan family. So on behalf of Narayan Nethralaya and GrowLab, Grow Research Lab, I thank both Dr. Rohit Shetty and DOS for giving me this opportunity to keep our work in front of you. Thank you so much. If there are any questions, I'll be happy to take it.
And stop sharing the screen, Thirumanesh. If I start with the question, so to summarize from what you did is that again, like what Dr. Sushma said in the beginning, you are bringing in a lot of immune factors driving CNVM, and just an anti-VEGF which blocks the vasculogenesis may not be the only thing. See, what happens is when you're looking at immune pathway, vasculogenesis is the dead end of the pathway. That means so many factors work on the vessel, knock, and then it knocks. The final unlocking is the blood vessel starts bleeding. And your VEGF blocks the last part of the pathway. But if the 10 knocks there, which is knocking on you again, will unlock it again as soon as the effect of VEGF goes. So one of the factors you are talking about is the angiogenin and the other unpronounceable substances there. And those are the ones which are above the level of just the VEGF, and they block it so that the work of VEGF is work of VEGF is not so extreme that it has to block everything. So am I right on this? Mm-hmm. And one of the issue, just to complete, one of the issue with VEGF is it blocks everything, even the healthy one it blocks in many times, especially when you're looking at it from an ROP perspective. Mm-hmm. So if you are finding those inflammatory molecules, even Anand has shown that in ROP also there are a lot of inflammatory molecules which makes the ROP2 flow. So all these new pathways are all inflammatory driven. So is this my summary right, or you want to add anything to this before we go to Grover sir and Namrata ma'am?
Exactly, sir. So actually, if you look at the initial progression from dry to wet AMD, it is the radical damage, radical oxygen damage, which initiate a low-grade inflammation, and it is the inflammation which actually switches on the angiogenic pathway. So when the chronic inflammation kind of starts damaging, it is the switch which tends to switches on the vascular pathway. But however, it also means that the inflammation is also traveling along with the VEGF. So at every point, it's not just the VEGF. Along with VEGF, the inflammation is also playing a part. but it is playing a part in the subretinal way. That's why we don't see any cells of flare. So many a times as a retina specialist and US specialist feels that if you say inflammation, where are the cells? But this is a very molecular way, or molecular signatures which are there actually indicate that inflammation is actually playing a very large role in both in CNVMs as well. And these potential targets have to be taken care of, or worked upon to give a complete treatment modality to CNVMs. Giving anti-VEGF will just end up giving an injection every month for next 5 years. So that's what we were working on the animal models. When Arka gave us the newer targets, he said that we should work on MIP10 and CXCL inhibitors and all that. Although it did work to a great extent, we were why we did not present was there were a few validations that he had to run, and he said, till we finish this, let's not get out with it.
So that means that you created an animal model of CNVM in a rat?
Yes, sir.
And you inject not the VEGF, but inject these molecules into that rat?
We had 5 groups of it, sir. So okay. In one of them, we gave a different molecule, and then we wanted to correlate them all together in one this thing. But I was the blind injector, so both the rat and me were blind with reference to what was getting injected into them. So the results are still not totally validated, so we're still not out with it.
Wonderful. I think that data, I think Namrata ma'am will surely allow you to present it sometime in the AIOS or one of the platforms in physical format. So Grover, sir, anything?
Superb validation of what you said at the beginning, that inflammatory mediators are working in a lot more conditions than we assume. As we know, in diabetic retinopathy as well, inflammation is playing a major role. In dry eye, how much of a role is being played by inflammation? So I think very good marker, very good indicator, and tells us how much more we need to be working on the inflammation aspect of CNVM as well, in addition to the anti-VEGFs that we are already doing. A really good work.
And again, I asked this question to Sushma. I'll ask this question to you. You mentioned these markers, fractalkine and all this thing. And if you want to pick up one, which we want to bring it to the clinical use, given a chance, angiogenin, or which one would you pick up? You mentioned close to 6 or 7 of them, actually, along with it.
Yeah, actually we analyzed for 38 to 42, sir.
Okay. One, you can pick up one.
We narrowed down to 10. It's a little difficult to point one, but from what I speak to Arko, he says that
give me two. In the
interest of more than picking individual factors, you should actually try and modify the gene. That's what his answer was. But if you allow me, I would probably use a broader blocker like a steroid. But I think fractalkine and IP2123 is what I would pick.
So this, if you want to manufacture this as an antidote to this, how do you manufacture this? This is chemically modifiable, or you have to take it from a human source or something and then do it? Or animal source? How is it done actually?
Usually, one product which actually surfaced onto the market or into the trials was the anti-complement. They saw that inflammation was activating through the complement pathways, so they came up with an anti-complement. But the problem or the fault in the design of the study was they did not use it simultaneously. They just gave the complement, and the final pathway was active, so they never thought of combining it together. So similarly, even when we design a trial or when we come up with these molecules, so these will be produced in bacteria just like how we present or produce.
Just 1 minute. If somebody gives an anti-complement and you put it in anti-complement into your retina,
yeah.
What I think is, even if there's one strain of your bacterial genome there, the next day morning, your patient will end up with endophthalmitis. And this genome of bacteria will mutate and it will become extremely resistant because your complement pathway is completely gone in that ocular milieu for that minute. This is what I feel is the major challenge with complement-driven anti-drugs. Because you cannot see, even in your surgeries, it's irrespective of how sterile your condition, you still enter a lot of flora goes into your surface, but they are quiet and they're killed by your antibiotic. But if your complement itself is low, it's like an HIV, AIDS, everything will flare up. That's a challenge. Anyway, wonderful work. We'll be very waiting to see your animal-based work sometime in near future. Dr. Jagdish Kankaria is there? Is not there, I think. Jagdeep Kakaria, Dr. Jagdeep Kakaria is not here. So do we have Dr. Sohail Ifran Mohammad Khan from the DOS backend? Is Dr. Sohail Ifran Mohammad Khan here?
Yes, sir, I'm here, sir.
Oh, wonderful, wonderful. Dr. Sohail, we are waiting for your innovation on pre-chopper. Dr. Sohail Ifran Khan's pre-chopper. Please share your presentation, sir. We have one more to go after this. It's been a wonderful meeting so far. Dr. Sohail, can you share your screen?
Second, sir. 1 second.
Dr. Grover, would you like to say anything on the past innovation till he's getting ready so that people are not bored of just waiting?
This has been one of the most educative sessions I've attended in a long time. I think it's really encouraging what our youngsters are doing with the encouragement from their mentors and what they are achieving all over the country. I think it's really very heartening for Indian ophthalmology. So we hope we come up with a lot more work which drives the clinical advancements. And these were all, fortunately, studies which were easily translatable into clinical work. Thirumalesh would help stimulate looking into agents other than steroids for the anti-inflammatory pathway, which would have lesser side effects, and it could do wonders for CNVM. And we need to be looking at all these pathogenesis and trying to get a lot more for the clinicians. The gene therapy will, of course, revolutionize things in its own time. But even before that, we have several other pathways to look at.
Is my screen visible, sir?
Not yet. We are looking forward to.
Can you have you opened your presentation on the desktop, Dr. Sohail?
Yes, sir. I'm operating through my mobile.
Oh.
Now,
I'm not really sure how to share screen on the mobile.
No, sir, I'm comfortable because I've done two presentation, but anyhow, backup is there with the DOS people. If Mr. Nero, who is there, if he can play my...
Sir, in your phone, you have a screen share option also. You have.
Already I have done.
So, sir, you get the option to select the screen, any one screen. Only select any one screen where you open your presentation.
Yes, now it is shared. Oh, no, actually, no. That's a video. Yeah.
So,
if you're facing the problem, then I can share your PPT.
Yeah, please you do it, because in the interest of time, let's.
Okay, sir. I can. I share the.
Please. Have you pre-recorded it, pre-voice recorded it, Dr. Sohail, or you want to give your voice?
Presentation. Few slides are there. Then afterward, my voiceover video is already there.
So your PPT you can see.
Yeah,
I can see.
Okay. Sir, I give you the remote control, so you can change the slide on behalf.
Okay. Can I flip the slide now?
Remote control and the कैसे share कराएंगे? આપણે અહીંથી કરવાનું रिमोट मी सेम सेम हेलो
या हेलो
हाँ सर आपको एक ऑप्शन आया होगा रिमोट का
जी जी
ठीक है आप अभी आप उस पर क्लिक करके वहां से आप चेंज कर सकते हो अपने पीपी
चलेगा Is it changing?
Yes.
Yes, Dr. Sohail, please.
Yes, sir. Somehow it's not making a easy transition. I'm having. May I request you to play my slide because I'm finding it difficult. Anyhow, my video is important because that itself is going to give a good amount of idea. Yeah, he is my guru. Of course, everybody knows him.
Sure, sir. I will change your PPT. Just
Next
tell me
one.
that change the.
Yeah, next one. Dr. Takayuki Akahoshi is my source of inspiration, who made me to think about a possibility of a new pre-chop technique, because I was a little frustrated and found a little embarrassing to copy his technique of pre-chop using his pre-chop forceps. Next one. Of course, we have shifted from conventional chopping to conventional. We are shifted from the 4-quadrant to chopping, because that decreases a lot of energy. But now we are thinking of pre-chop for the simple reason that you can use a mechanical energy to divide the nucleus without the use of phaco or femto, which in itself has got a huge amount of advantages that we are going to see. Next one. Of course, there is a drastic reduction in the amount of the phaco energy used in a pre-chop technique, and the aspiration time and the amount of the BSS used in the antechamber is reduced, thereby reducing a huge amount of turbulence that is created, especially when you are dealing with a very hard cataract. And pre-chopping can also be a very zonal friendly, and therefore it makes the entire procedure faster, easier, and safer, as we are going to see subsequently. Next one. Compared to a femto-assisted cataract surgery, we have seen a lot of femtosurgeons struggling to separate the fragmented pie-shaped pieces of the cataractous lens, which have been subjected to laser. At the same time, a small pupil is a challenge for a femto laser surgeon, as well as a deep-seated eye is another big challenge to dog the laser. Next one. Now, this is a modification. MyLoop is a modification of Keener's snare technique to fragment the cataractous lens, but nonetheless, it also involves blind manipulation and having a steep learning curve. And PCR is a known complication that has been documented quite well. Next one. Of course, if you want to imitate a Akahoshi technique, all the forceps are looking alike, and where to use which one is a problem, as well as it has got a very steep learning curve. So I am presenting my own patented instrument, which I call it as a pre-chopper, which has got a very sleek design, and it doesn't imitate any it's a cross-acting pre-chop forceps, and therefore the interchamber stability is comparatively much phenomenal. And I'm using a Chang chopper or a Akahoshi's ball nucleus sustainer as a second instrument to hook the equator of the nucleus. Of course, it has got a very sharp edge to cut the nucleus of any density. Next one. Next one, sir. Yeah, this is a schematic representation of how the chopping can produce from starting from the left side, top to bottom, wherein you divide the nucleus into two and then rotate to obtain a 4 quadrant or 4 pi. And if you have patience, you can almost get 8 pieces of the nucleus. Next one. And if with patience, you can get almost 8 pi shape quadrants. Next one. Now please play the video. It has got a commentary also, voiceover. Please play the voice. So if that is not possible, am I audible?
Yes, sir, you are audible. You can use your voice.
Yeah, I'm showing a very dense cataract being pre-chopped. I'm using in my left hand a Chang chopper device to hook the equator of the nucleus, and through 2.8 millimeter, I'm using my designed pre-chop instrument to fragment the nucleus. So by subsequent rotation, you can divide the nucleus into 4, 5, or 6 number of pieces, which can be easily lifted from the capsular bag, and at the at the capsular or a iris plane, you can emulsify. Of course, this is a viscoelastic dependent technique wherein you have to use a lot of viscoelastic. This is another intumescent cataract, which is, of course, a dense cataract being pre-chopped. I think the only step that need to be mastered is the hooking the equator of the nucleus. And you need to stabilize your left hand after hooking the equator of the nucleus to stabilize it, and then use through the main incision this sleek pre-chopper just anterior to the margin of the capsule, so that it can be divided into 2 heminuclei. There is another one. Now this is a Chang chopper which I am hooking, and this is the pre-chopper which I am inserting just anterior to the capsular axis margin, near down, and then piercing into the endonucleus and going through, cutting the endonucleus to produce nice, beautiful fragments. With a little bit of rotation, again, you can divide it. Has it stopped?
Yes, the video has started running again.
Yes. I'm very thankful to Namrata Madam, Dr. Grover sir, Dr. Shetty sir for incorporating me in this innovative program.
Okay, sir,
Now-
can I stop the video?
No, it's still there.
Okay.
Now this is addition to that you can use it for soft cataract, which at times can be challenging for the surgeon in the sense that there is a lot of cheese wiring, and when you apply your phaco power and vacuum, the cataract vanishes and you don't get a adequate amount of hold. So this is a technique where which is very much suited for even the soft cataract. It is hardly a 3-4 minutes. I think I'm demonstrating this in the use in a SICS also. This is a intumescent cataract wherein I am trying to deal with by aspirating the anterior lens cortex by the needle, but unfortunately I succumbed to something called as Argentinian plaque sign, and then that is one of the complications which nobody want to confront, and I have to convert it into what is called as pseudorhexis by cutting at the 2 borders, and then making a pseudorhexis-like thing. But the thing which I want to impress upon the fact is that this technique, because the impact of the Chang chopper and the pre-chopper are against each other, and therefore even in this situation, which is a scary situation for any phacosurgeon, because the forces are being impacting towards each other, it gives you a phenomenal amount of stability, and you can even overcome this kind of dreaded complication. And after that, there is a small video of a 1.5 minute demonstrating the applicability of this technique in SICS surgeon. Yeah, this is in SICS, wherein I'm designing a less than a 2.8 millimeter incision with a 0.5 millimeter back cut, and I'm dealing with almost a 2+ grade cataract. It's a very short video. Here I'm using a Akaushi nucleus sustainer rather than a Chang chopper to hook the equator, and applying the same principles. It's a fairly dense cataract. Once you divide it, you can use any of the vectis, whichever you are comfortable. I'm using a non-irrigating vectis, and just depressing the posterior lip of the incision to remove those fragments, and finally put a foldable lens. So this can also be an alternative technique for SICS surgeon also. Last few second video, I think it is lasting for 30 seconds, less than 30 seconds. So I'm applying a white cataract, intermittent cataract. That's it. I think that is the end of my presentation.
Thank you, Dr. Sohail. I think the beginning you did mention your three inspiration, Dr. Lane sir, your teacher, and Dr. Akaushi. I think your videos do justice, and they'll be proud of your innovation. I would like to ask Chairman Dr. Grover sir to give his thoughts and questions from this videos.
Dr. Sohail, a really good innovation. It'll work for hard cataracts, for soft cataracts, difficult situations where rhexis has been lost. Really a good innovation. The only thoughts concern the learning curve of going over the equator and bringing in a blunt chopper from behind, or a blunt instrument from behind as to serve as the base. So that will be the only limiting step. You'll have to give us your results with other surgeons. You've become very proficient at it. So once the other surgeons use it and we get the feedback that they are able to do it as well with the use of your instrument, then that will be the real success of the instrument.
Yes, yes. Thank you very much.
Tirumlesh, Dr. Sushma, anything you want to add? Tirumlesh also is a good cataract surgeon, and Sushma also, along with glaucoma, is an excellent cataract surgeons, both of them. So, and Amar also, Amar Pujari is here, all three of you.
Very useful, I would say, particularly when you have those total intumescent cataracts and you're worried about, and you already have an extension or something and you're worried about further extension. I think this can come handy. Very interesting, I would say.
Rumlesh, do you think that a young novice surgeon will require your assistance when they use this? His camera is off.
Should pray for it, go down and pick it from there.
Yes, sir. Dr. Sohail, how do you decide the depth of the chopping? What is a rough judgment when you want to introduce the instrument? So to what extent you want to go the deep? Because in the equator, the lens is going to be much thinner compared to the central portion. So what is a rough guide to say I have reached enough depth?
Initially, when I start entering into the endonucleus, which is anterior to the intercapsular margin, actually my direction is oblique. It is never heading towards the optic nerve. It is actually oblique entry, and it has been designed in such a way that it has got two variants. One is 1.4 to 1.5 millimeter, that cutting edge, and the another one, which is meant for hard cataract, is almost 1.8 millimeter. So even in any of the cataract, is not going to go and hit the posterior capsule. But you have to be extremely consciously aware of the fact that when you are hooking the equator of the nucleus, your aim is to start just anterior to the intercapsular margin obliquely in a slanting way and go and hit the Chang chopper, which is the equator, which is hooking the equator. So your intention is to actually go and collide with the second instrument. So that really bails you out of the situation of that kind of fear and anxiety and the possibility that we can go and rupture the posterior capsule. Okay. I have never succumbed to, of course, I have succumbed to another complication wherein I have hooked twice the intercapsule margin and produced a minimal amount of zonular dialysis. And then I had to overcome that in the beginning of my learning kind of learning curve. But otherwise, producing a frank PCR is something which I have never come across. I'm applying for all cataract. This has become my routine technique. I'm not doing any chopping now. I'm doing pre-chopping in polar cataracts, wherein the rotation is something forbidden. I'm doing it in PXFs also, where zonules are weak, and therefore you cannot do other kind of maneuvers, especially the vertical chopping, wherein you can induce a torsion and good amount of zonular stress. So it's a kind of a mind block, I think. Once you try to hook the equator, initially you need to be a little generous in the size of the capsular axis. You don't want to go and hook the equator of the nucleus. So you have to be consciously aware of the fact that your second instrument is almost straddling across the cortex and the endonucleus and going below the intercapsule. So even I apply a maneuver wherein I try to empty the anterior cortex and epinucleus with the help of a Simcoe, so as to improve my visibility.
Dr. Sohail,
yes,
one advice we'd like to give from this group is that, like what Dr. Ashok Grover said, you can give this chopper to few surgeons, including the surgeons around here. There are a lot of young surgeons here, and let them all use it. And then I think one thing most important is you have to publish it. See, the reason we speak about Akahoshi or any chopper is they make a quick thing and they publish it before it becomes somebody else's domain. So the way forward from your innovation is, otherwise what will happen is it'll become only yours, and like the same question what Grover sir asked is going to be asked by everybody else. We have seen that your videos you are an excellent surgeon. Your hands, the stability, everything looks so fantastic, including the Argentinian flag sign, you're able to do this procedure, but the ability to reach everybody is going to be the way your technology is going to be judged in the future. If the technology is just going to be judged by one or two people, then it's going to be a very limited, it's not going to reach everybody. So I request you to see if you can make those choppers and give it to all the surgeons, including in this group, starting with the Grover sir, and collect all the videos, get the data, and write the paper and publish it. And you could start with IJO itself, and then it will become really a widespread use.
And also, Dr. Rohan, we need a Miyagi Apple view of this cutting. So, Dr. Rohan is here?
Yeah, he's here. So if you can
Yes.
Not the
Rohit is a
point.
very
Not the
good
point.
cataract surgeon. If you've given it to him, I'll tell him we can do a Miyake Apple view of it.
And I think you should also share your experience regarding how do you judge the depth when you're putting it beneath. Because from what I see in majority of the pre-choppers, many of us or many surgeons for that matter were afraid that there will be a stress on the zonules and all that. So what are those tips that you want to give to somebody who's trying this when they're trying to put this pre-chopper to a certain level, or when you started from the opposite side of the equator? At what level do you stop, and how do you judge that you are at the right depth?
Yeah, just now I have explained in detail, but again I will start right. Just enter to the intercapsular margin, and my direction is oblique, and my aim is to go and hit the second instrument, which is hooking the equator. So it is. I'm not actually directing my instrument to the like posterior pole or the optic nerve. It is not directed towards the center of the capsule. It is oblique. And that's the most important thing which one need to understand, that the second instrument has also a role to play. And either it could be a Akahoshi or a Chang chopper. When you are trying to, bring the pre-chopper towards the Chang chopper or a Akahoshi, the same maneuver you are repeating on the other side. So that is also being pulled towards the center. So both instruments are moving towards the center. Once the crack develops, you can actually spread these two heminuclei to fragment even the leathery posterior fibers. So I would say it's just a question of just give a try as per your convenience, and then you can realize that it can be a very, very easy, and because it has got a very sharp cutting edge. So I'm not telling that it can be applied for the general masses that go for a grade 4 or a grade 5 cataract, which doesn't fit into any of the international classification of cataract, because we tend to see very hard cataracts. So, but for you start with like Pradeep Mohanta sir is also using my pre-chopper, and he's doing in soft cataract alone. So he's also an example as a how a novice surgeon can adapt to this technique so wonderfully. So some of the videos are there from Pradeep sir.
Thank you. So thank you, Dr. Sohail, and please apply for a patent if you can.
It's already patented, sir.
Already
patented.
Please take the group and start. Please publish it. That's the most important take home from this. Wonderful surgery and wonderful instrument.
Thank you very much, sir. Thank you very much.
We go to the last presenter today. Dr. Santosh Agarwal is here. And
yes, sir.
Yes, sir.
Yes.
So,
good afternoon, sir.
Good afternoon, and pleasure to have you here. And we would like to share your presentation, and then we'll have some small discussion on this.
I think Niro is there. I think he will present on my behalf.
Yes, sir. I can play your video.
Yeah, please. At the outset, I thank DOS for giving me this opportunity, and respected Grover sir, Shetty sir, and all others. Very good afternoon to everybody.
So can I start?
No, this is not my video. A second video actually.
Sir, we got these. So we got only these videos.
Yeah, you can play this video, no problem. This is also innovative way.
Santosh Agarwal. I am going to present an innovative way to deal with cataract. This is a small device which I have used, that is a 26 gauge needle. It is bent as shown in the video. Intumescent cataract, there is a lot of intracapsular pressure, and many times during it can escape, and Argentinian flag sign is very common. So to deal with and to avoid this type of mishap, I have developed this is a simple device, that is a bent 26 gauge needle. I have attached to the aspiration tube, and simultaneously I pour from other side the visco inside the, and now I pierce the capsule off center and aspirated the cortex and relieved the pressure inside the capsule. From the other side again, from 6 o'clock, first I did at 12 o'clock, and then from the 6 o'clock I again did the cortex inside the capsular bag. Now this is the bent cannula which I used to take 9 o'clock and 3 o'clock cortex, which is at the mid periphery, where the pressure is very high and the capsular axis can escape. So this is to relieve the capsular pressure so that your capsular axis will be done easily. So two side ports are made. Now I have aspirated cortex and relieved the pressure inside the capsular bag. And now I am going to perform the capsular axis. As the pressure is relieved, the chance of escape of capsular axis is very low. The important point here is that only central pressure, if you relieve, still there are chances of escape of CCC, because there is a lot of cortex in the mid periphery and where you are going to perform the capsular axis. Many times, even if you relieve the pressure in the center by taking the prick in the mid peripheral hipped up portion can give way and your CCC can escape. So very important to relieve the pressure 360 degree. Now this is another intumescent cataract, again at 6 o'clock and 12 o'clock side ports as usual. This is a SICS case. Now again the bent needle is pierced inside the capsular bag anteriorly. It is aspirated as shown in the video, and this aspiration is done aspiration tubings which is attached to the aspiration port on the phaco console. Now from the another side again is made in the capsule. So from multiple sides I have done on two sides at 12 o'clock and at 6 o'clock. Now it is replaced with the bent cannula and the cortex is taken out from other sectors so that simultaneous pouring of the visco is mandatory so that your antechamber is maintained, your capsular surface is flattened, and less likely chances of capsular escape. This is another case. Now here I have directly punctured in the center and aspirated the cortex periphery to the extent possible to relieve the pressure inside the capsular bag. The aspiration is used from the IA, aspiration cannula is used, and now directly I perform the capsular axis. This is another method to deal with the intumescent cataract, but it is bulky instrument, so many times the capsular opening becomes larger and it can create a problem. So bent now is another way to deal with intumescent cataract. Here I found that the capsular portion is flattened with only pouring the visco inside the antechamber, and I perform the capsular exit with ease. Now another, this with SICS, the two side ports, there are different ways to deal with intumescent cataract, but I found the bent 26 gauge needle is very helpful. It creates only small opening or puncture in the capsule, and simultaneously you are pouring the visco through other ports so that your AC is maintained, and aspiration is done through the bent needle. So pressure inside the capsular bag is relieved and the AC is also well maintained. So, and it will also press the capsule from anterior side. So this is the simultaneous aspiration and pouring the visco inside the antechamber. This is the usual SICS method. So this is a very rewarding method to deal with intumescent cataract. I didn't find any of my case which has got Argentinian flight sign, and I could do justice to the intumescent cataract patients. Thank you very much for your kind listening. I am Dr. Santosh Agrawal. I am going to present an innovative way to deal with intumescent cataract. This is a small device I have used, that is a 26 gauge needle. It is bent as shown in the video.
Repeated, I think.
Intumescent cataract, there is a lot of intracapsular pressure.
Okay, sir.
Okay, thank you.
Santosh, wonderful. Thank you for such a simple innovation. Like to request anybody in this panel, start with Dr. Grover, sir.
I mean, the principle is highlighted well, that you need to decompress the positive pressure, intralenticular positive pressure. A number of surgeons have put forth their techniques. The only risk that we sometimes have is that even with the initial small openings, sometimes if the pressure is too high, it goes on before we've been managed enough aspiration to go into an Argentinian flag sign. So concomitant use of a high viscosity viscoelastic is essential. And I couldn't really see because there was jumping in the video. You're making multiple openings with your, Dr. Santosh. You're making multiple openings with your needle from 12 o'clock and 6 o'clock at different positions.
Yes, sir.
And then you go through one of them to do the aspiration on the horizontal, on the other sides, right?
Yes, sir. Yes, sir.
Okay. Yeah, so this illustrates the principle very well and would work.
We have to relieve the pressure from 360 degree. Otherwise, it can escape from that sector.
True. The only risk is that if the intralenticular pressure is very high, sometimes even with the initial small openings, they sometimes tend to extend and go into an Argentine.
But I go with the aspiration on, so that it will take out the pressure immediately.
Pooja, would you like to say anything?
Yes, I would like to say, sir, like it's a brilliant innovation and it's very useful for all the surgeons because the idea here is to decompress your anterior chamber. But as Dr. Grover also said, and I also had the same thing, if you create multiple openings, and you have two instruments, that itself is a scare because if you're putting aspiration at the same time and you're putting viscoelastic, there aren't there higher chances of the capsule opening up? Like that is what for any intumescent cataract.
Yes, because we are pouring the visco inside the anterior chamber, that will press the anterior capsule, and you can decompress the capsular bag easily, and you are simultaneously aspirating the cortex. So, and why I'm making two openings? Because from one opening, it can get enlarged. If we manipulate it more, it can get enlarged. So I make two openings, and that too from the side port, not from the main wound, so that my anterior chamber should not get decompressed.
Okay, sir.
Thank you. Anybody else? Any questions?
Sir, one thing I want to add.
Yes, Amar.
Dr. Santosh, if you look into these mature cataracts, there are mainly 3 articles in literature. One is from Punjab. Dr. Dhami has said you can do ASOCT preoperatively. Another is Dr. Titya, our senior professor from RP Center, have said IOCT can help in quantifying the interlenticular changes. So similarly, I studied around 44 eyes and we found that all advanced mature cataracts are not going to have interlenticular fluid. They are not going to have raised intra-bag pressures. So it's better you can do OCT. So that will say what is the amount of liquefied matter, how convex the anterior capsule is. If it's too much convex, so that means that there is a raised intra-bag pressure. So better you can do ASOCT, you can quantify the amount of liquefied matter, then you can proceed. Even though whatever the number of punctures you are doing, that experts are going to differ. But if you consider OCT, you can better quantify what is the amount of fluid. So when you are aspirating, you can quantify, okay, I removed everything or like it might be remaining. So that can add on to your surgery.
I think even if you don't have, like a lot of people might not have an OCT, but even when you are staining your capsule, like this is what our teachers had taught us, even if you're staining the capsule, if the trypan blue like goes towards the periphery, it means that your center is bulged and there's a lot of fluid. So that itself is a sign that there is you need to be careful, and that's when you can have this technique.
Yes, that indicates the increased convexity of the anterior capsule, raised intra-bag pressures.
Yes.
Also on slit lamp, many times you can realize the fluid cortex.
Exactly.
Thank you, Dr. Santosh. I think we have come to the end of this session.
Thank you, sir.
And just to sum up very quickly, and then I'll ask Dr. Grover to give his points. One is we started out with a very good presentation by Amar. He spoke about the role of anterior segment OCT in looking at the posterior polar cataracts, is new classification, a great innovation. Then we have Sushma completely trying to redefine glaucoma as could be a huge inflammatory component and how we had to treat it. Then we had Rohan speaking about his camera, and the Miyake Apple camera has always been an enigma for a lot of clinicians. I think you're bringing it closer. Dr. Pooja spoke about the collagen imaging, which has huge impact in virtually every aspect of ophthalmology anterior segment today. And this is not just collagen. The wavelength of this is deeper. It can go up to the lens. And I think Eventually, I was telling Pooja that you should also look at the capsule. Collagen, everywhere there is collagen, you can study. So what Dr. Amar said can also be studied from the posterior polar part of the capsule, because that is wherever, whatever collagen properties are, you can study. And that's a very nice way of looking at it. Then we had Tirumlesh going into his aspect of defining the CNVM as an immune complex. John, as usual, has a beautiful video which helped us to smile and laugh, and also go introspect into what is really needed when times go tough. And I'm sure that he will come out with something for these people who can practice at home. Reading is one thing now, you'll have to practice also at home. And Dr. Suhail's wonderful innovation on the chopper, I'm sure we are ready waiting to him to publish, because every time an Indian publication comes, it also gives you that inspiration and drive that, okay, he can do it, we can also do it. So more and more of this publication, like how we speak about Akahoshi chopper, I think people should talk about our choppers and our instruments. And then we had Dr. Raju speaking about his innovation, and which is already seen clinical use. We had Dr. Prakyat coming out with it, and happy to see it in a box format. Anytime I see an innovation in a box by any company, it means that it has really defined the role of an innovator. I think it could be, and Pooja and we were also happy that one of our innovations when she started her PhD became a Trehalose drops. Now, a lot of companies are talking about Trehalose. So all this, I like that. Innovation to a box is what I say, because that box defines everything. And we had Dr. Santosh Agarwal speaking about his innovation for cataract, and I think everything was wonderful today. And I leave this summing up to Dr. Grover and then Dr. Namrata ma'am if she's free.
I think we are being inspired by the youngsters. They have made really some presentations which should inspire us to do more for them and for the Indian ophthalmology. And I'm glad Namrata is here, and the AIS office has done a lot to encourage the innovators, and I'm sure we'll come up with more help for the innovators to move forward with their patents and so on. Namrata.
Thank you, sir. Thank you, Rohit, for doing this, for again showing us another, another way of looking at things. And I think we have done a lot of innovative webinars, but I think we should not limit ourselves to webinar. That is not the true service that we would be doing to these innovators. The true service would be, as Dr. Rohit very rightly put, if we do have a patent lawyer, if we do have a patent office, and if they don't have to pay for it, the AIOS takes the onus upon itself, depending upon the innovation. So I think that is the next step forward, and that has been the message for us at AIOS. And I think when you do brainstorming sessions like this, and when you see things, and when such innovative and so many thinking minds think together cumulatively, such solutions come out. The next step is going to be just implement these solutions. So thank you, Rohit, again for doing this great session with all the youngsters here, all the young female youngsters here also. I'm so glad to see Sushma, Pooja, and of course all the boys. I'm so happy to see all of them. And again, thank you very much, Rohit.
Thank you, ma'am. Thank you, Grover sir, for staying.
Thank you, Namrata and Rohit, for putting this together. Really educative session.
Thank you, everyone.
See you.
Thank you all the youngsters.
Thank you, everyone.
Namrata ma'am, give us 2 hours next year in physical format whenever you conduct the meeting.
Any number of hours, Rohit. 2 hours is not any number of hours that you want. 6 hours, 4 hours, 5 hours, physical meeting done. Thank you so much.
Thank you. Good day.
Bye.
Thank you, ma'am. Thank you, sir. Bye.
Hello? Praful? Hello, Praful? Rakesh, right? So participants are joining. Praful?
Yes, ma'am. Good afternoon, ma'am.
No, participants are joining because I don't see very many people. I don't even see Prashant and
I don't know. I think we'll have to join as delegates. Then only it may be visible.
So please upgrade everybody. Admin, please upgrade everybody to panel. Sai is also not there. Are they on some other format or where are they?
Only Sohini is there.
No, is it?
Sohini? Sohini is there as attendee.
No, what happened? Sai, where are you? I can't see you on the platform hall. See, is it a different platform? You're redirecting to a different platform. Where do you have to go to? You have to tell, no? It's a no Zoom पे ही हूँ ना मैं Zoom हॉल सी में हूँ कहीं और है क्या Yeah, Praful, it's a different link. It's not this link. Praful, Sohini, Praful, Dr. Rakesh Rai, Dr. Yogesh, it's a different link. I think I'll ask them to post the link here.
is most likely to be correct. So your options are option A, dense bilateral cataract should be removed before 3 months of age. Option B, residual myopia is targeted while calculating IOPAR. Option C, should be diligently preserved. And option D, post
Visit to participate in the quizzing one there.
இந்த மெயில் எனக்கு வரலையே.
அது வந்து நீ கொஞ்சம் நிறைய ஸ்டெப்ஸ் பண்ணணும். எப்படி வருது? அதுக்கப்புறமா எப்படி கடுப்பாகுது. யார்கிட்ட கேட்க? ஓ இப்ப வருது.
ஆஹோ.
Yes.
Okay.
Stroke length is the length of the needle movement during to and fro movements, while occludability is the tendency of the tip to get occluded and it builds up the vacuum. Frequency is the speed of the needle movement. Stroke length power varies by varying stroke length and frequency. Tip selection depends upon the lens removal technique and the hardness of the lens. While the low frequency cause is less efficient, the higher frequencies causes excess heat. So coming to the
Hello. Can't hear anything. Like, is the quiz going on?
ओए इसमें चल तो रही है यार जैसे इनकी क्लास चल रही है
Now this is the isotonic and you
क्या
just
कह रहे
pick it
हो?
up.
अभी हॉल सी है ना, वही खोल के बैठे.
You can see these access marks.
अरे तो लिखवाया कितना कितना बिल बनना है? हैं? इसमें लिखवाया बिल कितना बनना है? अरे हाँ कर दो.
No.
The tip that I use is 0.3.
देखो देखो मैंने जो न्यू वाला भेजा है, हाँ ये सी में भेजा
All
है,
the debris
क्योंकि मुझे पता था
here,
ये कॉइन वाले ना
got rid
रुकेंगे
of.
ही नहीं, ये तो चलते जाएंगे अभी. हाँ.
Important to get rid of all these to offer the best possible optical quality to the patient. We now load the Trio lens. And Trio has so with a little support.
Good evening, Dr. Rishi, Dr. Naushid Shroff. This is Dr. Shkeen Singh.
Good evening, Rahul.
Good evening, Dr. Rahel.
Hi, Noshir. Hi. Hi, Dr. Shakeen.
Hi, sir. How are you?
Hello everyone, can you hear me? Hello, hi Rishi sir, hello Noshi sir. Everyone can just switch on their webcams so we'll be able to see each other. Hi Ashwini. Your mic is muted. Hello Lalit sir, hello Shakeen sir. Hello
Good
Martin sir.
afternoon, everybody. Good afternoon, all seniors.
So the live surgery session is just finished and Dr. Chaudhary is just joining in about 5 minutes.
Hi Rishi.
Hi Lalit, how are you?
क्या बोर हो रहे हैं? Hi Noshir, President Saab. President Saab is muted.
Good evening, Dr. Lalit.
Shakeen Singh, क्या हाल है Shakeen?
Sir, good evening.
सत श्री अकाल, सत श्री अकाल.
सत श्री अकाल, sir.
क्या करना है राहिल?
So शुरू करते हैं. So should I start or just waiting for 2 minutes for everybody else to join in?
We have lot of
4:30 हुए नहीं है वैसे.
हाँ हुए भी नहीं है अभी.
Sir Lalit sir, you white hair में बात बनी नहीं sir. You used to look much more smarter.
अभी हो जाएगा वो भी टाइम बदल.
COVID is bringing effect.
The smartness never goes.
Yeah, so eventually person becomes more classy.
देखो राहिल का एक भी नहीं है.
So मेरे अभी
ये तो अभी 25 साल का है. ऋषि also is hardly 35, 30.
अमू यार. तेरे से 6 महीने छोटा हूँ.
Namrata Sharma is not joined or she is busy in GST.
I think ma'am is occupied with the live surgery, so just finishing. I think last surgery is going on.
कहाँ से हो रही है?
Sir, अब I7 से ही.
अच्छा अच्छा अच्छा. Tityal has joined. And sees the icon.
Tityal has joined, but his profile photo has changed.
नहीं, that was the photo शुरू से.
Really?
Namrata has joined.
Ah, here he is.
जीवन सिंह मास्क पहन के क्यों बैठे हुए?
I have another meeting going on at my place.
अच्छा अच्छा अच्छा.
Hi, Jeevan. Hi, Namrata.
किसके घर में बच्चे चिल्ला रहे हैं? नम्रता?
नहीं, मैं तो ऑफिस में बैठी हूँ सर.
नम्रता के बच्चे छोटे नहीं हैं.
मेरे बच्चे छोटे भी नहीं है और मैं ऑफिस में बैठी हूँ. मेरा ऑफिस है.
ऑफिस में बैठी?
3 मिनट में यहीं बैठी हूँ इसी सीट पे.
ओह. टिटियाल भी ऑफिस में है?
नहीं सर, घर पे है. सर अभी तो लाइव सर्जरी करके गए हैं सारी.
अच्छा अच्छा. ओहो.
नम्रता कौन से ऑफिस में हो आप? डॉस ऑफिस में, एआईएस ऑफिस में?
सर मेरा
यूनिट ऑफिस,
मेरा अल्मा मेटर ऑफिस, मेरा आरपी सेंटर का ऑफिस.
मैनेजमेंट कमेटी ऑफिस में.
आरपी सेंटर.
क्या बात है डॉक्टर तिरत्याल, मजे ले रहे हो?
आरपी सेंटर ऑफिस में सर.
Very cool, like that Namrata and team has done a wonderful job,
yes.
Conducting this.
Thank you, sir.
Of web conference.
Audible.
The amount of hard work they put in for last so many days.
So many months.
So many months.
नहीं months तो नहीं है. That is what is commendable is so many days में इतना अच्छा कर दिया.
Months तो practice हो गई ना. नम्रता तो expert हो गई है.
नहीं, जैसे जीएसटी बोल रहा था ना कि वो कुछ महीने एआईओएस, कुछ महीने डीओएस, कुछ महीने फिर.
नहीं सर, ऐसे नहीं.
अभी मंडे से एआई शुरू हो जाएगा.
क्या शुरू होगा?
राइट ऑन करना था पीछे.
एआईओएस का कुछ शुरू हो जाएगा ना.
हाँ.
सो ऑनगोइंग है. नम्रता के लिए आदत पड़ गई है इसको.
नहीं सर, ऑनगोइंग कुछ भी नहीं है.
अरे बहुत मुश्किल काम है नम्रता. तुम कह रहे हो अचीव करना इतना आसान नहीं है जो तुमने कर लिया.
I'm thankful to Dr. J.S. Tityal sir and to RP Center for not, for making everything so smooth for me.
उनको पहले थैंक बोल देते हो ना, वो बेचारे कुछ बोल ही नहीं पाते.
नहीं sir. I'm really thankful to them. इतना support नहीं होता तो कुछ नहीं कर सकते थे.
Namrata को support नहीं चाहिए. She's herself is such a strong lady.
No.
She does so many things with so much of sincerity and commitment. That is what I like.
Namrata सुबह energy boost पीते हो boost?
नहीं.
Boost is the secret of my energy.
बूस्ट नहीं पीती, बूस्ट पियोगे तो फिर क्या होगा आप सोचो.
टिटियाल वार्निंग आई है, बूस्ट पिए तो क्या होगा.
नहीं इन्होंने तो बहुत काम किया है. Like they worked in a not only human serum, they worked in a cord blood serum also. अब समझ लो क्या पीती होगी.
बेकार तो खून पियो.
बूस्ट तो दूर की बात.
क्या हुआ Rahil? You're waiting for Dr. Sanjay Chaudhary?
Yes, ma'am. Yes, he's just joining in about 5 minutes.
Do we have all the
Actually, he was supposed to come home and join this session, but I suggested to stay there and join in. So he's just logging in. In the meanwhile, I can just introduce. So everyone, hi, I'm Dr. Rahil Chaudhary, and we have a new kind of a session here.
कहाँ से आवाज आ रही है भाई? किसके घर से आवाज आ रही है?
सर मल्टीटास्किंग कर रहे हैं सर, उधर टीवी भी देख रहे हैं और इधर मीटिंग भी.
Not seen TV for since morning, you have engaged me right in the morning, I thought I'll see cricket match, वो तो पहले ही खत्म हो गया 2 दिन में. बिल्कुल सारा मूड खराब कर दिया.
पूरी खराब हो गई सारा वीकेंड खराब हो गया.
The way they played is horrible, And I was discussing with some other people, it's the fault of a selection committee. They have not put a single left-hander in the, in the batting lineup.
मुझे नहीं डाला ना left-hander.
हाँ सर देखो, नौशीन सर कितने
लेफ्टी हूँ.
कितने डिकेड से बैटिंग कर रहे हैं, बताओ कोई आउट ही नहीं कर सकता उनको. That's a mistake, they have not put a left-handers. वो बंदे उनको कुछ फील्डिंग भी चेंज नहीं करनी पड़ी. हाँ. They kept on bowling in one place,
नहीं बहुत फर्क पड़ता है.
और सारे हमारे बैट्समैन एक ही स्टाइल के खट्टे और चलते गए बस.
नहीं वो सब हमारे बैट्समैन T20 खिलाड़ी हैं बस.
सही कह रहे हो.
वो खिलाड़ी हो तुम मारो बस मारो आउट हो गए बस. टेस्ट क्लास जो है ना कम होती जा रही.
इतनी खराब फील्डिंग मैंने देखी नहीं पिछले कई सालों से यार. The way they were fielding.
वो पार्थिव उसके ऊपर तो कुछ साइकोलॉजिकल प्रेशर हो गया. वो तो फर्स्ट ओवर में आउट होना ही है उसको.
और बेचारा तो अब वो तो उसका तो खत्म हो गया टेस्ट कैरियर जो है.
फिर भी उसको काफी लंबी रोक दी है यार.
हाँ. राहिल आप शुरू करो 6 बजे GBA में, तो कब या डिस्कनेक्ट कर देंगे.
राहिल ये तो आधे घंटे में हो जाएगा.
And I just request everyone to switch on their webcams. So basically the session is inspired from the Oscars, the Filmfare Awards, and we are following a similar kind of a pattern here. So we got about 132 entries, and of course I would like to thank all the people who participated, who sent their entries, and of course the judges who were given all of this at a very short notice, but everybody did a very good job. So thank you all for actively participating. So I have a promo ready here. So I'll just show you a promo, and then I'll just request the anchors, Dr. Namrata ma'am and Dr. Chaudhary, to take the show forward.
I also made the toricity of the lens is maintained that the central points, which are markers of the lens, are exactly at 0 and 180.
नहीं ये तो कुछ और चल रहा है.
इधर कुछ और आ गया.
स्टोरी का ही वाला.
Live surgery continuing.
Dr. Dipankar and
ये तो कुछ और.
And Dr. Grover is still in the live surgery. He'll just get free in 5-10 minutes. Dr. Rahil, can you hear me?
So I invite Dr. Namrata ma'am and Dr. Chaudhary to kindly take the show forward.
Okay, so can you hear me?
Yeah.
Yeah, hi. Welcome to DOS Oscars. With the help of Dr. Namrata and the entire faculty of DOS, they have been kind enough to give us this opportunity to start a new educational session so that we encourage the youngsters to come out with their videos, and we honor the best videos and encourage young talent from all over the world. In fact, Dr. Namrata is aware that this time we had a huge participation from Arvind, right, Dr. Namrata?
Yeah, all over the country, and
all over the country. Yeah,
representation from all states and the entire country.
Yeah. So what we have done is that we have divided the whole process into 4 categories. The category 1 is on complication management. Likewise, we have innovative and others. And we shortlisted the best 16 videos out of the whole lot. Once our doctors went through the entire list and said these are the top in each category. So we sent the top videos to the judges. Our esteemed judges looked at those videos and decided which is the best video. Now we will call for the nominations of the videos in each category. And then we would ask the judges to declare in them who is the winner and who gets the Oscar. And once the winner is called, the judges of that category can talk to the concerned doctor about his video or highlight some good points of what made them select this particular video or their suggestions on what is the way forward. So I request Dr. Rahil to please move on to the nominations.
So category 1 was on complication management in cataract surgery.
You can see your screen computer, but not the promo video also was not visible.
Sir, please close the folder and open VLC player. Then you can see.
Either you embed in PPT or you open VLC.
But can everyone see the video?
No. We just see the nomination 1, 2, 3.
So first you play the video and then close the folder.
Okay. What I'll do is I'll just share my whole screen. Can you see it now?
No.
Once you play, then we'll come to know.
Sir, play the video, then open VLC. Okay, sir.
Yeah.
Can you see the video now?
Yeah. But we have to play the video. It's not playing.
Yeah. Now, can you see the? I'll just pause the video in the middle.
Let it play. Yeah. Play. It is jumping as if the signal is weak.
I'll try to make it smooth. pausing the video in between. Can everybody see the video clearly?
No, we can see there's no commentary with it.
No, it's,
Yeah, so this video without any.
Sir, kindly click the double click on the screen so you can get the full screen of video.
Yeah, better.
Coming hazy.
Yes, sir. Yes, sure, sir. Done. Now play.
The video is very unclear.
Better. Second.
This is the first case we have seen where the IOL went into the corneal stroma.
Could it go into the corneal?
Has any of the faculty seen such a situation before?
How did it reach there?
I am wondering how did
playing the second nomination, which is the Femto PCR by Dr. Ankush Mahajan.
Here we present a case where during femtophaco, during the femtolaser part of the procedure, because of a mistake by the surgeon, the laser fired too posteriorly and caused a posterior capsular tear. During the procedure, the surgeon pressed down on the femto handpiece to maintain suction during the firing of the laser. As a result, the laser fired with a very posterior focus. All of the energy went inside the intact lens capsule bag, and some of it also created a posterior capsular tear. This was immediately recognized by the surgeon as the anterior chamber became very shallow. There were no air bubbles inside the anterior chamber, and it looked as if all the energy had went inside the bag. This was a nightmare scenario because the surgeon realized since all the energy had gone inside the bag, so he was now probably dealing with a posterior capsular tear also. Step, there were no incisions, so the incisions had to be created using knives. Second step, intracameral epinephrine was injected first of all inside the anterior chamber to keep the pupil well dilated during the procedure. A side port was created. Next, capsulotomy was found to be absent as well. So a new capsulotomy was created using the capsulorhexis forceps in the regular fashion. All the time the surgeon was praying to God that maybe there is no posterior capsular tear and maybe he'll escape without doing any vitrectomy in this case. The PCR was already anticipated, so hydrodissection was avoided. Only the hydrocannula was used to slightly depress the nucleus at one end and the other end in order to dislodge the air bubbles which are there posteriorly and to do a slight hydrodelineation. To prevent a nucleus drop, the phacoemulsification parameters were brought down. IOP was brought down to 20, flow rate of 20, and a vacuum of 350. All the time the surgeon was hoping maybe the PCR will not happen, but alas, this was not to be the case. And during phacoemulsification, the surgeon noticed that yes, suddenly, here you can see there's a capsular tear, the air bubble goes posterior. The phaco tip is kept in its place, irrigation is stopped, second instrument is removed, and with the second hand through the side port, viscoelastic is injected inside the anterior chamber as well as posterior to the posterior capsule, so in order to prevent the vitreous from prolapsing anteriorly. The vitreous space is secured. Further phacoemulsification of the nuclear matter is continued, taking precaution in order to put vacuum only when the tip is buried in the nuclear substance rather than giving vacuum in the anterior chamber and pulling out the viscoelastic. Very slow, deliberate motions are used. Now, Viscoelastic is again injected through the side port, making sure the complete interior chamber is filled with it, and the phaco tip is withdrawn very carefully out, preventing any shallowing of the anterior chamber and breaking of the vitreous face. Thankfully, this was a soft nucleus, so the chopper is used to mobilize the subincisional areas of the nucleus so that this nucleus can be removed easily using the phaco tip later on. At all instances, AC is maintained. Viscoelastic is used for viscoscretion of the nuclear material as much as possible so that a nucleus drop does not happen. The majority of the nuclear material had been expressed out using the viscoexpression technique. Then the next difficult task was to do a thorough anterior vitrectomy and cortical removal in order to clear the way for implantation of an IOL later on. The vitrector is used in the IA cut mode with a cut rate of 2500, a flow rate of 20 and a vacuum of 300. The vitrector is used to remove the cortex thoroughly as well as to do a thorough anterior vitrectomy, as leaving vitreous behind can later on lead to vitreous prolapse and it can cause problems later on. Since the capsule had been cut very thoroughly with the femto laser, so that it was not possible to create a posterior capsular excess, hence a vitrectomy was done and the AC prepared for IOL. So normally single-piece hydrophobic lenses are not recommended in the sulcus, but here the eye was very big, AC was very deep, so it was decided to implant the trifocal lens in the sulcus and an optic capture was done to decrease the overall touch of the IOL with the black part of the iris.
Two lenses and a scaling.
All the wounds were hydrated and closed.
So this was the second video by Dr. Ankush Mahajan. And now we have the third video by Dr. Kiranjeet Singh.
Are you showing the complication, all the complications videos?
No, sir, only the nominations. So there were 3 nominations for the complication management category.
3 nominations. Okay, so you show about 3 in every category. 12, you show about 12 videos.
Yes. So now number 3, which was by Dr. Kiranjeet Singh, who demonstrated anterior and posterior capsular excess in onion ring cataract.
Oval, anterior and posterior capsular rhexis in a case of onion ring cataract. This is the patient, onion ring cataract. An oval capsulotomy is being done after staining the anterior capsule.
Can anybody in the faculty
Easy
recognize
enough.
the voice?
Beautiful oval capsular axis.
Daljit Singh.
How much he sounds like Dr. Daljit Singh, huh?
Yeah, that's what
It
I
does.
This is not a Daljit Singh voice.
It is his voice.
This fluid injection is not right
I know,
Welcome,
Chef.
sir.
You see,
Hello.
and could be a cause of posterior capsule rupture. Phacoemulsification started as usual. An oval capsular axis, long oval capsular axis, prevents the rise of fluid pressure in the capsular bag and prevents the dislocation of the nucleus into vitreous. Now, very carefully, the lens matter is being withdrawn and we see a rupture in the posterior capsule, an opening in the posterior capsule. Hold the posterior capsule and pull it and have a long capsulotomy parallel to the anterior capsulotomy. And now from this side to the other side. So you have produced a double oval capsulotomy. All that remains is putting an implant into the bag, which is very, very easy because there is so much space for the optic and the haptics to go. So there is absolutely no problem in lens implantation. No vitreous was lost and no anterior vitrectomy was needed. A complication was produced during surgery, but it was managed beautifully. You see the double capsulotomy.
So this category videos were judged by none other than Dr. Grover and Atul Kumar, and they were unanimous in their opinion about the winner. And I request Dr. Grover to spell out who is the Oscar winner in this category. Dr. Grover, sir.
Thank you, Dr. Sanjay. All the three films were very nice. They were all ingenious in their approach and managed the complications beautifully. But both me and Dr. Atul felt that the third film by Dr. Kiranjit was the best. It conveyed a very simple technique, a very simple message, but did it so very well that a simple thing like making the anterior capsular axis oval prevents the increase in intralenticular pressure during your surgery, and the posterior capsular axis, again oval in the same axis, allows the lens to be placed so comfortably, and how to avoid the complications due to a pre-existing rupture were all conveyed very beautifully and very simply. So that is the winner of the Oscar.
Wonderful. So do we have Dr. Kiranjit here with us at the moment logged in? No. So congratulations to Dr. Kiranjit. A very thank you, judges, for the first category, and congratulations, Dr. Kiran, for a simple yet a wonderful presentation. Sir, as judges, would you like to comment on anything further about or anything from your experience about the winner's video?
Yeah, I think the pre-existing now, I think what has happened is that the anteriors are used to detect existing tears very well. A number of patterns have been described. There's a lot of work from the RP Center as well as from Mahipal, where the anterior segment OCT allows us to know better that there may be a pre-existing tear pre-operatively, and you can then plan the management better and do it beautifully, like what we saw from this video film in Dr. Kiranjit, with of course all the standard precautions that you take in a posterior polar cataract of avoiding hydrodissection, avoiding increased intralenticular pressure at any stage, and avoiding collapse.
Thank you very much, sir. And may I request Dr. Namrata now to take over and present the second category. Dr. Namrata, please.
Yes, so we come to the second category. Rahil, can we have it?
I'll just play the video. Before that, I would just request all the judges to kindly check their WhatsApp group again. There's a message which I put on the group which would just help you with the whole process and everything.
So can you announce the judges of the second category, Dr. Namrata?
Yes, so the judges of the second category are Professor J.S. Tityal, Dr. Sudhang Bharti, and Dr. Gaurav Luthra. Can we have the first video, Dr. Vidushi Sharma, piggyback IOL implantation?
I'm Dr. Vidushi, and in this video we describe the pearls for piggyback IOL implantation. Piggyback IOLs can be implanted either to manage refractive surprises in a secondary manner, or primary piggyback IOL implantation may be done in cases of high hyperopia which need a very high IOL power. Before any piggyback IOL implantation is considered, we must ensure, of course, that the anterior chamber is of adequate depth and size, there is no pigment dispersion syndrome, and for secondary piggyback IOL implantation, the first IOL should be well centered within the capsular bag. The IOL power calculations for piggyback IOLs is slightly different from routine IOLs. For primary piggyback IOL implantation, as mentioned in the Dr. Hill website, we first need to, of course, accurately measure the axial length. Then we calculate the total IOL power needed in a routine manner. This total IOL power is then divided between the two IOLs that we will be implanting, one in the bag and the other in the sulcus. The IOL that is to be implanted in the ciliary sulcus, the power needs to be modified based on the positioning, and we also need to select the appropriate IOL combination, for example, a hydrophobic acrylic and a hydrophilic acrylic, or some such combination. For secondary piggyback IOL implants, if there is a residual myopic refractive error, we multiply the spherical equivalent of the refraction at the spectacle plane by a factor of 1.15, and in residual hyperopia, we multiply the spherical equivalent refraction at the spectacle plane by a factor of 1.25 to achieve the IOL power that needs to be implanted. This, of course, is an approximate calculation, and more advanced formulas like the Holiday Consultant software are available to calculate the exact IOL power based on the spherical equivalent refractive error, as well as the keratometry readings, anterior chamber depth, etc. Coming to the surgical technique, it is generally preferred to implant a 3-piece IOL in the ciliary sulcus, and we should never implant a square edge IOL to minimize the chances of iris chaffing. In cases of high hyperopia with short eyes, when we do a primary piggyback IOL implantation, we must always protect the corneal endothelium because these have relatively shorter eyes with shallow anterior chambers, and therefore coating the endothelium with a dispersive viscoelastic is extremely useful. Now, this is a case of high hyperopia with a refraction of +8 diopter sphere who wanted freedom from glasses. The IOL power calculators was 34.5 diopters, and because the toric and multifocal toric IOLs were available only till a power of +30 diopters, so a piggyback implantation of multifocal and a toric IOL was done to achieve spectacle independence. This is the surgery being performed with the marking of the steep axis, as is the routine practice for toric IOLs. We then coat the endothelium very well with a dispersive ophthalmic viscoelastic device. The main incision at the steep axis and the side port incisions are made. And a good capsular excess, because for all these refractive IOLs like toric and multifocal, a perfect centration within the capsular bag is of crucial importance. Bimanual irrigation aspiration was done. This was a soft lens, so phaco was hardly needed. This is a +19.5 diopter toric IOL available from Care Group India, which is being implanted in the capsular bag. The toric IOL is then dialed into place, achieving a proper positioning along the astigmatic axis. Finally, the viscoelastic is removed from under the IOL, and the final positioning of the IOL is then checked to align with the astigmatic axis. Next, we implanted an Acrodiff multifocal IOL, again available from the Care Group India. The standard practice is to implant one IOL into the bag and the other IOL into the ciliary sulcus, but in this case we implanted both the IOLs in the capsular bag because for both the toric as well as the multifocal IOL, proper centration within the capsular bag is crucial to their proper functioning and good refractive results. Finally, the viscoelastic is removed from between the IOLs as well as from the anterior chamber, and the postoperatively the patient gained a vision of 6/9 and N6 unaided and was extremely happy with the results. So to summarize, primary piggyback IOL implantation can be done not only to achieve a high IOL power in cases of high hyperopia, but different combinations of monofocal, toric and multifocal IOL implantations can also be done in a piggyback manner, which is a viable and useful option for patients who need a very high power IOL and also to achieve good refractive results as well as spectacle independence. Thank you.
So
present
this is
a
the second
case
video
of
by Dr. Sri Ganesh.
management of subluxated cataract with iris coloboma in a case of high myope. Routine phacoincisions were made with 2 side ports and 2.8 mm main wound. Iris hook was placed to aid in the visualization of the capsular axis. Capsular axis was started.
20.5 diopters length, and it's a purely hydrophobic lens with aspheric surface. Zero aberrations, no aberrations. You can very safely put in all of the eyes with
26 gauge cystotome away from the area of subluxation, and it was completed with the help of a microcapsular forceps. Gentle hydrodissection and hydrodelination was performed, following which a capsular hook was placed in the area of subluxation to provide strength to the bag. After this, a CTR, that is the capsular tension ring, was implanted using a double hand technique. It was carefully placed inside the bag with the help of a dialer. Phacoemulsification with direct horizontal chop was then performed. Following the completion of the phacoemulsification part and aspiration of the cortex using coaxial, capsular hook was then taken out, following which a 27 gauge needle was fed with 6-0 Prolene suture, and it was passed 1.8 mm behind the limbus in the area of subluxation for the fixation of CTS. The suture was taken out from the main port with the help of micro forceps, and then it was passed through the eyelet of the capsular tension segment, and modified double flange technique was used to fix it using the heat cautery. CTS was put inside the eye and placed at the proper position, after which the iris hook was placed to retract the opposite part of the iris for better visualization. A foldable IOL of +6 diopters was placed in the bag. As the IOL completely opened in the bag, it provided the bag the added strength and also centered it, after which the suture of the capsular tension segment was pulled for proper centration and fixed with the heat cautery. Three sphincterotomy cuts was given on the opposite part of the iris, opposite to the iris coloboma, to release the tension and help in the fixation of the iris coloboma, as beautifully described by Dr. Amar Agarwal, the single pass pupilloplasty. The SFT technique was done to fix the defect of the iris with the help of 9-0 Prolene suture. Four passes of single pass 4-throw pupilloplasty were made, and then the suture was retracted on both the sides to appreciate the 4 passes, and thus helps in fixing the defect of the iris. The AC was properly washed for the remaining viscoelastic, and also if any blood particles were inside, and then the main port as well as the side port were hydrated. The patient did really well the first post-operative day. Thank you.
And this is the third video by Dr. Ashwini Kumar Behra.
Respected all, myself Dr. Ashwini. Here is my video on triple trouble, which is a case of post-traumatic operated trabeculectomy with thin cystic bleb with cataract with genular dialysis and iridodialysis to manage all these three cases in one sitting. Now coming to our case, we can see superiorly there is thin cystic bleb, inferiorly iridodialysis, there is a cataractous lens, and you can see genular dialysis from 5 o'clock till 7 o'clock. The location is marked 2 millimeter away from the limbus. Now the scleral flap is made. Initially it is planned for a Cioni fixation because there might be more subluxation that can be visible. Now scleral flap is elevated. 2 MBR entries are made. Superior MBR entry is made very carefully by the virtue of superior thin cystic bleb. Now AR, ADRI and dye injected, dye is washed, viscoelastic injected in the AC. Now the inferior genular dialysis part is protected with viscot. Now further 2 entries made for iris, use of iris hook, so that people can be expanded, which will facilitate the rhexis. Now we can see well dilated pupil. Now rhexis started. During rhexis we are not able to visualize the rhexis. Now with the help of painting technique we injected some dye, then over it viscoelastic. Now rhexis is completed. Since the rhexis appears to be small, now the rhexis is enlarged with the help of intravitreal scissor and forceps. Adequate rhexis is needed in such cases. Now 2 further entries made for hooking the capsule on the genular dialysis part. Now hydrodissection is done. Proper hydrodissection and hydrodilation is necessary in such cases to remove cortical matter easily, so that less stress on the genules. In such cases primary chop is always done, because with the help while doing sculpt there will be more stress on the genules, which will enhance the further genular dialysis. Now in between the hook from the capsule is got slipped, so now again the hook is placed in position. Now phaco again started, phaco completed with the help. Now cortical matter is removed. Before removing the phaco tube, viscoelastic injected from the superior MBR entry. Now since on table we examined there is less genular dialysis, we can manage with CTR. Now in CTR is implanted in the bag. Single piece lens is implanted in the bag. Now all the hooks are removed. Now coming to the iridodialysis part, 1 o'clock there is another entry is made for the 9-0-proline, and 2 millimeter mark through 26 gauge needle is entered. With the help of handshake technique, the needle is inserted into the 26 gauge needle. Now it is brought out. Similarly, on through the same site, another loop is brought out. Now it is titrated, well titrated, so that will give a hangback type feature to the iris. Localized vitrectomy is done because there is little amount of vitreous on that site. Peritomy is closed with the help of 80 Vicryl. Visco is performed, viscoelastic is removed. Now before coming out, air is injected. We can see there is this dye in the bleb. Now it is the first post-operative day, so the triple trouble is managed well. Thank you all.
And this is the 4th video by Dr. Shakeen Singh.
Greetings to all. We will be presenting a case of highly vascularized scarred flat cornea being taken up for triple procedure penetrating keratoplasty with PCIOL. We have no financial interests in this presentation. This is the pre-operative picture of the eye. The surgery starts with careful trephining of the scarred cornea. Extreme care is taken of the underlying adherent iris or uveal tissue, which needs to be spared. While opening, we could make out that the scarred corneal tissue is thick and smudged with iris tissue. Going very carefully, we dissected the cornea off from the adherent iris with blunt dissection and at times taking the help of 26-gauge needle to separate the uveal tissue from the cornea, securing maximum uveal tissue intact. Proceeded with the further steps with the corneal button still attached to be prepared for any threat of expulsive hemorrhage or untoward event. The pupil was missing in realm and needed to be digged out and refashioned by cutting the fibrotic tissue with the help of scissors. And we could expose a good pupil. Now we are trimming off the recipient bed. Hypermature sclerotic cataract is dealt with. Capsulotomy could not be completed with 26-gauge needle cystotome or forceps. So we had to resort to scissors to cut the capsule. Nucleus is prolapsed. Though things seem easy, but managing loose cortex with friable and loose iris tissue was quite a tough job. IOL is implanted and dialed to secure posterior segment. Remaining cortical matter is washed off. Suture is taken on iris to construct the round shape of pupil. The root of iris is reconstructed by suturing to the base of the recipient bed. Carboxymethylcellulose is poured over it to make a bed for donor button. The graft is secured with 410-0 nylon stay sutures. Keratoplasty is finished with continuous suture. AC is washed off any visco and formed with air bubble. Suture knot is buried and subconjunctival injection of gentamicin and dexamethasone is given. These are post-operative day 1 and day 7 pictures of the eye. These are 1 month and 8 month post-op pictures. These are the post-op auto-rep readings and anterior segment OCT of the patient. patient is happy with best corrected visual acuity of 6/24 after 9 months. Thanks for patient viewing.
So I think we had very exciting videos of in this category, and I would request Dr. Sudhang Bharti to please, sir, announce the winner.
Myself and okay, here. So, Dr. Winner of this segment of complication management in ophthalmology, the winner is Dr. Ashwini Behra. Congratulations, Dr. Behra, for this wonderful film on the complication management.
Thank you, sir. Thank you so much.
Congratulations, Ashwini.
Thank you, ma'am. Thank you, ma'am.
Sir, one word from you regarding this surgical video, and then from Dr. Chetyal, sir, and Gaurav.
I think this was a very interesting video on the management of more than one things in the same day. There's traumatic cataract, iridodialysis, and also subluxation of cataract, and along with the previous surgery which was done earlier from for the glaucoma, the trap surgery, and he has managed it very nicely. And I think this is one example of how you can manage these situations wonderfully well. And there's a good message for the audience for that. Yeah, thank you.
Thank you, sir. Thank you so much.
Dr. Chetyal, sir.
Yeah, Ashwini, well done. Really, congratulations. You managed this case so beautifully. All the difficult situations in a one single case. In fact, all the videos which have been shown here, they were tough and they managed, very effectively. Ultimately, the surgery should be such where the outcome should be, as good as you do a normal surgeries. So, Ashwini, wonderful, and keep it up. Very good.
Thank you, sir.
Terrific.
Thank you, sir.
Gaurav?
Yes. Thanks, Namrata. I think all 4 videos were brilliant, and I really enjoyed watching all the 4 final videos. And yes, Dr. Ashwini's video, showed how to, make it easy. He made it look very easy how he could manage so many complications which he encountered during the surgery and so many things which were repaired. It was a very challenging case. So on the head of complications, I think his video was definitely very deserving, and heartiest congratulations, and very well organized, Dr. Chaudhary and Dr. Namrata.
Thank you. Thank you so much.
I think with this, we'll move to the next category, Sanjay.
Yeah. So in the next category is the category of innovative techniques. And the judges in this is Dr. Rishi Mohan, Dr. Rajesh Sinha, and Dr. Partha Vishwas. So,
very beautifully with this. I'll put in the viscoelastic and I inject my lenses.
So I request
used to do them under.
I request Dr. Rahel to please play the nominations and the judges to take over and decide who is the most deserving candidate.
we demonstrate aerosol formation during phacoemulsification and a novel way to contain it. In this COVID-19 pandemic, different views and outcomes are published about aerosol formation during phacoemulsification. We realize even high-resolution cameras used in research studies detect particles of size more than 20 microns. But we also know that the average diameter of a SARS-CoV-2 particle is 0.125 microns. Also, the World Health Organization defines aerosol as particle of size less than 5 microns. So, is there a way to precipitate particles of such small size? Yes. Aerosols can be deposited by dry and wet methods. Dry deposition happens when the aerosols collide with solid obstacle, and wet deposition happens when the aerosols coagulate with water. Keeping these physical properties in mind, we used a physical setup to contain visible and invisible aerosols if generated. Our idea is to modify the readily available test chamber into a safety chamber which can contain the aerosols. Let's now see how we modified the test chamber. We need an inverted pear-shaped opening for which a 3 mm trephine is used to make a circular opening, and it is converted to 4 mm pear-shaped opening using scissors. We cut short the length of the thicker portion of the test chamber to 10 mm. Here in GORE Sci with 2.8 mm corneal entry, we can observe the droplets and aerosols generated at the site of the tunnel whenever ultrasonic energy is delivered. To know the efficiency of our novel safety chamber, we tried it over the same 2.8 mm channel of GORE's eye. Surprisingly, we found no escape of droplets and aerosols. Here in this mature cataract, a dry modified test chamber is inserted and phacoemulsification is being done. Due care is taken that this opening made in the test chamber is of optimum size with dimensions of 3 into 4 mm so that it does not slide forward and hinder the visibility of the surgery. Ideally, operating room needs 2 air exchanges in 6 minutes. But not every theatre is fitted with this facility. Hence, the ideal way to safeguard us from the aerosol is to contain it at the source. Here, if we carefully observe, whenever ultrasonic energy is delivered, we are able to note that there is accumulation of fine bubbles which we believe to be precipitated aerosols that are generated at the tunnel. We do agree that these aerosols may be generated just from the balanced salt solution that is leaking, but there are reports indicating the presence of COVID-19 virus particles in the conjunctival secretion and tear films of affected individuals. Now the concern is, does it interfere with the field of surgery? No, we didn't observe so. For example, in this case, when the surgeon is not reminded about centration of operating microscope, the safety hood is barely visible during surgery. Also, it is important for the surgeon to ignore looking at the safety hood during surgery, just the way one ignores images of the operating microscope light over the surgical field. We conclude our safety chamber would be more beneficial in cases of hard cataract and short tunnels. Since it is a simple modification of readily available device, it can also be used in all cases of phacoemulsification and also with vitrectomy probes to ensure safety for healthcare professionals. Thank you.
I am Dr. Santosh Agrawal. I am going to present the video on an innovative visco chopper through which the visco can be delivered inside the entry chamber. It acts as a two-way function. One, it acts as a chopper and also as a visco delivery system. So this is applied to the silicone oil port or the vitrectomy port on the console, and the silicone oil system is used for this purpose. Instead of silicone oil, we use visco, and this is the knob on the foot pedal which is given by the company for activation of this port. You can see the VAPI port on the console which is specially made for this purpose. by Turbovit Appasamy machine, and this is a challenging case, white cataract. The intracapsular pressure is very high, so it is very difficult to perform the CCC in such cases. And as the visco is delivered as and when necessary, you can make the anterochamber deep, as well as you can see the peripheral extension of CCC can happen at this moment. So we can inject the visco at this moment and we can avoid this peripheral extension of the CCC. This is the intumescent cataract. We are extracting the liquid cortex from the capsular bag through the tiny opening, and one is injecting one port. Through one port we are injecting the visco through a automated visco delivery system, so we can take out the fluid cortex. At the same time we can inject the visco. Now this is the PC rent which has taken place, and to avoid the extension of the PC rent, we can inject the visco inside the anterochamber through this chopper, so that the anterochamber depth is maintained, IOP is maintained, and the visco will take care of PC rent and the vitreous. Now this is the small pupil. Again, it is very difficult to perform the CCC, so visco can be delivered and you can have CCC with ease. This is another case of hypermature cataract, challenging situation. Here I used AC maintainer to deliver the visco. You can maintain the anterochamber and you can extract the fluid cortex, the liquid cortex, through the main incision or through the extractor. This is another challenging situation where the last piece of the nucleus, while removing you need good AC depth, otherwise PC rent can happen. This is another challenging case of lens-induced glaucoma case. Corneal edema is there, iris is coming out through the wound, lot of IOP pressure in spite of all measures. We have taken anti-glaucoma measures. So this visco inside the anterochamber can give you protection from the endothelial damage. This is another scleral fixation IOL case where a lot of manipulation is required and the chances of hypotony is there. So to avoid that, through AC maintainer, visco is delivered inside the anterochamber and the IOP is well maintained. Pediatric cataract case, the CCC is very difficult because of obvious reasons: elastic capsule, less rigidity, scleral rigidity. So to maintain the IOP and anterochamber depth, visco is delivered through the AC maintainer. This is a hard cataract, supra-hard cataract. Endothelial damage can happen in routine cases, but with the help of visco, you can avoid that. And this is the manual way of delivering the visco inside the anterochamber through the visco chopper. And initially I showed you the automated technique. So this helps in a complicated cataract cases, phaco cases, to deal with the endothelial damage, to maintain the AC depth. The manipulation are easy and to perform, and the PC rent also can be managed very well, and we can avoid the PC rent in most of the cases. This is the silicone oil system which we have utilized for this purpose, and especially visco chopper is made by a 26 gauge needle, and the special handle is made by the company. Thank you very much for your patient listening.
Anterior stromal puncture for toric IOL. Errors can occur while marking associated with smudging or fading away of dye during pre-operative reference axis marking. Anterior stromal puncture creates a point mark without any epithelial erosion, and the simultaneous staining helps in perfect and long-time retention of the dye. Thus, ASP stain stays for more than 48 hours. In case the need to re-rotate the IOL occur, there is no need to mark again. Dr. Fog. Fogging of microscope eyepieces and fogging of spectacles causes blurring of vision during surgery. Defogger solution used by divers in deep sea diving and by miners while mining on their protective goggles helped in solving this problem. Low cost, high definition Raspicam. Raspberry Pi Camera is a fully functional Linux-based computer that can be fitted with a HD camera module. An adapter, which is portable and also small enough to mount the Raspberry Pi, can be fitted to the Observer eyepiece. It has a better quality than the more expensive commercially available systems like conventional camera, and mobile phones is more portable and records videos in high resolution. 5-cent Airway for patients to breathe easily during surgery. The lanyard that is thrown away after each conference can be reused in this manner. The one end of the lanyard is tied to the microscope and the other end is clipped onto the drape during surgery. It also has a sliding note to adjust the drape height. Locked-in switchboard. To prevent accidental switching off of OT refrigerators that store drugs requiring low temperatures by the OT staff, the refrigerator switchboard is locked in with a wooden box, thus maintaining the cold chain. A road with marking can make your work easy. A metal road with marking helps fix the table height and chair height for a specific surgeon with ease. This in turn helps in theatre flow and ergonomics. COVID-19 safe intubation hood. A simple structure made from PVC pipes and plastic sheets. This intubation hood will minimize the spread of micro droplets and aerosol while intubating and extubating the patient. OT trolley sanitizer dispenser. It is portable and foot pedal controlled. It helps in hand sanitization by the OT personnel at frequent intervals. Whiteboard in OT. Phaco under topical anesthesia requires patient's utmost cooperation. A whiteboard with details of patient operating eye, IOL power and design in the operating room helps the operating surgeon with patient details at one glance in patient interaction and also help in cross-checking patient details. Clutter-free OT table. OT tables often get messy by patients' case sheets lying on them. A clutter-free OT table can be achieved by fixing a simple side tray to it for keeping the case sheets and IOL. TAFE, Spring Action Apparatus for Fixation of Eyeball, is a robust, simple and economical device to solve the problem of achieving a formed and firm eyeball which is stably fixed in a holding device in surgical wet lab training. The spring action syringe generates vacuum and enables reliable fixation of human and animal cadaveric eye on the iron cylinder. The rise in intraocular pressure due to vacuum fixation can be varied as per need or nature of surgery. Magnifier screen. Magnifier screen is a simple tool that can be used to read fine prints of automated printouts and match IOL labels before cataract surgery without using presbyopic glasses by surgeons, thus making the time out before a surgery more convenient for the surgeon. Microscope simulator or simulator box. To avoid the confusion for patients to focus on the light during phaco and plaques and help them focus, we have devised two simulators mimicking the light source of operating microscope and plaques laser, which are shown before surgery to help the patients to know what they see and what they must focus. Subtenon LED. Subtenon LED for performing the subtenon's anesthesia where a clear view of block site is imperative. The device consists of a headband to be worn around the head by the doctor performing the anesthesia. It has a white LED light in center. This helps the doctor to see the patient's block site clearly.
An eye of a cataract surgeon with an intraoperative OCT. The authors have no financial interest in this presentation. The introduction of OCT into the operating room OR, called as intraoperative OCT, IOCT, provided new insights into the surgical management during ophthalmic surgery. The Discover and Pioneer study have been evidence of applications of IOCT in the field of corneal and vitreoretinal surgeries, including lamellar keratoplasty, ILM peeling, molecular hole surgery. Now get ready to view from the eye of a cataract surgeon through a variety of cases performed using an IOCT. Scleral corneal tunnel in manual small incision cataract surgery, MSICS. In this case of corneal buttonhole, IOCT was instrumental to confirm the adequate depth of new tunnel without disturbing the superficial plane. Clear corneal incision of keratome. Intraoperative OCT has been used to assess morphological features of the wound like length, breadth, and the number of planes in real time. Clear corneal incision femto. Here we see the plane of entry of a femto wound with a spatula, and adhesions or laser uncut areas can be identified, and IOCT can guide the surgeon prior and plan ahead. There was a cavitation or gap between the corneal surfaces even before the manual opening. IOCT provides real-time assessment of CCI morphology and DMT. Sclerotic anterior lens capsule. In this case of sclerotic calcified anterior lens capsule, we can observe the extent and depth of ALC plaque, and IOCT aids in visualizing for any adhesions and stability of capsular bag. Posterior polar cataract. Phacoemulsification in PPC is a challenge to anterior segment surgeons. PPC with intact capsule is assessed by IOCT. Here we can appreciate in real time the physical separation between the epinucleus and the endonucleus. Following hydrodelineation, phacoemulsification is performed safely with clear visibility, separation between the posterior polar plaque and the capsular bag with safe viscodissection. The epinucleus is separated and the aspiration of cortex is done, ensuring no PC dehiscence. Phacoemulsification. Learning curve in phacoemulsification. With the MIOCT, novice surgeons can visualize the exact depth of trenching in context of its distance from the posterior capsule, which will be of utmost importance in cases where red reflex is not visible. A case of traumatic cataracts. In this case of traumatic cataract with 4 to 5 clock hour zonular dialysis, CTR is guided safely into the bag, and the weak bag with folds becomes stretched back to normal after CTR insertion as seen in the IOCT, and stability and centration of IOL was confirmed. Iris hooks. Small pupil in cataract surgery. Synechial release is performed with spatula, making 4 side ports at parallel to the iris plane and about 1 mm posterior to the sclerolimbal junction to achieve a more physiological retraction. The proper placement of the iris hooks and gradual enlargement results in a pupil size of fixamen. The iris raised, iris platformed is assessed. IOCT helps to visualize and assess the challenges faced with improper positioning. In a case of resurgery following complicated cataract surgery with PCR, IOL in sulcus and residual cortex beneath the IOL, as seen in the video with the IOCT, we were able to assess for remnant cortex seen as hyperlucent areas behind IOL and ensure complete removal with the vitrectomy cutter. IOL centration and stability were confirmed with IOCT. Loop technique. Using microthin superelastic, self-expanding nitinol filament technology, it fragments the nucleus. The challenge lies in injecting the filament loop under the anterior lens capsule. Here we can visualize the filament passing between the cortex and posterior capsule as a hyperintense shadow moving across just above the posterior capsular plane, and churning of the cortex is noted. Conclusion. IOCT technology also has its own, such as shadowing from instruments, lacks eye tracking systems. But we just witnessed that it is imperative to realize intraoperative OCT, IOCT is an emerging modality with the potential to revolutionize the surgical techniques of cataract surgery by improved individual surgical management and patient care. Thank you.
So before I request Dr. Rishi to declare the winner and give it comments, we also have Dr. Noshir with us here. Dr. Noshir, any comments on the innovations? Dr. Lalit, are you around? No. Dr. Rishi Mohan. Yeah, Dr.
no,
Lalit, any comments on the innovations?
I was fascinated by the IOCT usage in various modality researches. I don't know who was the innovator or the video, but it was truly innovative to see so many videos being shown and the applicability of the intraoperative OCT. That was my observation.
Fantastic. Dr. Rishi, your observations and declaring the winner.
Yeah, I think before I declare the winner, thanks Sanjay, thanks also for giving me the opportunity to see such wonderful videos. I greatly enjoyed looking at all of them. And yes, I agree with Lalit's observation about the ASOCT. It's a fascinating tool. And I think a couple of years ago, it would have probably won this category hands down. But now it was in a tougher fight on account of the other innovations that are also alongside. The cinematography as well as the editing was brilliant, as were the concepts of some of these novel innovations. I was very impressed with the simple way of using the test chamber to reduce the aerosol formation. And I thought that was quite a good way to reduce the aerosol in the current scenario. I was also impressed by the use of the irrigating chopper. That would, in certain difficult situations, yes, with the continuous flow of viscoelastic, would certainly help maintain the chamber. So that was a wonderful innovation as well. But I think the winner, which was Dr. Shivraj Tagre, with his video, he had 10 innovations in one video. And I think, so congratulations to him.
Thank you, sir.
For a wonderful collection of innovations, all in one video. And I think they would individually go a long way in helping surgeons, as well as in this case, patients who were being able to give a simulation of a model of what to look at and which light to concentrate on. And I thought that was very impressive. And I think in the end, the hallmark of a good video is that you want to see it again. And to me, that was something that this video made me do. And so I thought that was the deserving winner. So congratulations again. But I think it was a wonderful collection of videos from all the contestants. So my congratulations to them as well.
Thank you. Congratulations, Shivraj. Great. You see, from the innovative point of view, I agree, with Rishi. But I like that IOCT. That's what. But Shivraj's video was quite innovative. If you were used even innovation, I think Sanjay, Rishi has done a great job.
So Shivraj, which place are you from? Can you?
You are from where, Shivraj?
Ma'am, my hometown is from Kolhapur, Maharashtra, ma'am. But right now I'm studying in Aravinda Hospital, Pondicherry.
So how do you feel getting this Oscar?
Sorry, ma'am. Sorry, sir.
कैसा लग रहा है ऑस्कर जीत के?
How do you feel getting?
I feel really nice, ma'am. But all these innovations, all the doctors in our hospital work throughout the COVID pandemic to make sure that all the innovations and all the new techniques are more oriented towards patient safety and patient care. So we came around 15 innovations during this 3 and 4 months period to minimize the aerosol dispersion, as well as make the surgery as well as the OPD practices as safe for the patient as they can be.
So must celebrate with everybody.
I think Dr. Venkatesh, who's in Pondicherry, Aravind Eye Hospital, has given responsibility to all of them to innovate during this COVID period. So they've done a great job.
Yes, Dr. Venkatesh sir has been a great mentor, ma'am. He has been a driving force to, to make as many innovations and as many think beyond the box to make sure you stand out of the box to make everything good for patient safety and patient care.
This was a team effort.
Yes, sir. It's definitely a team effort.
And the confidence
especially with the
mentor has
Dr.
in his
Venkatesh.
I think that is the most important thing.
Yes.
Very good.
And before we go to the last category, can I just ask Dr. Kiranjit to just show himself? And Dr. Naushir, please, he won he's the winner of the first category, the Oscar.
Where is Kiranjit? Can't see him.
Dr. Kiranjit.
Hi, Kiran.
Yeah, there
How are
you
you?
Hello.
Kaise ho, Kiranjit?
Hi, Kiranjit. Congratulations.
Hi, Kiranjit. Congratulations.
Thank you, sir.
You have your father's voice here. Exactly remembering Dr.
all of us
Daljit
were saying it Daljit Singh ki awaaz hai.
Yeah. When he was very ill, he was putting his sound in my videos. So I have kept them with me, and everywhere I present my videos, the sound is there.
Achha, this is your father's sound, this thing?
Yeah.
Okay.
नहीं वो तो फिर हमारा डायग्नोसिस ठीक था इसका मतलब.
हाँ, इसका मतलब हमारा क्यों ललित?
Yeah, हमारा डायग्नोसिस ठीक था.
We hit the nail on the head there.
Yeah, we felt that Dr. Daljit, I have been very close to Dr. Daljit Singh, so I know this is Dr. Daljit Singh.
Yeah. So he said, I have very little time left. So you give me all your videos. I'm going to fill my voice in those videos.
Wow, how nice.
How nice.
Chalo, congratulations, Kiranji.
Thank you, sir. Thank you.
Great.
And Dr. Namrata, can you call in for the next category? I think I'll take it up. She would have got busy with the GBM session. So the category 4 is Dr. Namrata on the line. Yeah, Dr. Namrata. Yeah, I'll do it. You are GBM shuru ho gayi. Right. I'll take care. Right.
Stamp the tunnel for a perfect small incision cataract surgery. The manual small incision cataract surgery is a boon to greater number of patients in developing countries, being cost effective and a sutureless technique. The major determinant of outcome in small incision cataract surgery is a sclerocorneal tunnel, as its architecture largely influences the induced astigmatism and proper delivery of the nucleus. The key components of sclerocorneal tunnel are scleral groove, side pockets, and corneal entry. Though there are various types of incisions described, the incisions that fall within Cox funnel induce less astigmatism. The Cox funnel is bounded by two imaginary curved lines which are 3 mm apart at the limbus. The frown incision described by Singer in 1991 is the one that falls perfectly inside Cox funnel and also provides large enough room to accommodate nucleus during the Making perfect frown incision is not always easy, especially for novice surgeons, due to limited movement of the wrist joint in ulnar side by nature. So it will be useful to have a guide to make appropriate frown-shaped incision. Similarly, appropriate side pockets are of paramount importance to convert two-dimensional tunnel into a three-dimensional one, providing a wide opening to accommodate nucleus during delivery. The beginner surgeons tend to make either two small side pockets landing in difficult delivery or two big ones which will not take part during delivery of the nucleus. The third key factor, corneal entry, is preferably made 1 to 1.5 mm from the limbus. If the entry is made more anterior, it induces more astigmatism, and if it is made short and posterior, it does not allow side pockets to open and deliver nucleus. For the benefit of novice surgeons, we have brought out a novel device, SICS tracer, which could guide scleral groove, side pocket and corneal incision, thus helping them to make a perfect tunnel. Here, this device is being used on a goat's eye in wet lab. This SICS tunnel tracer is carefully devised using 3D printing technology with appropriate dimensions so that the scleral incision falls at 2 mm from the limbus and the corneal incision falls 1 mm from the limbus along with a margin which guides to make side pocket. It has prominent margins which helps to stamp the tunnel shape before starting sclerocorneal tunnel. After aligning the device to the limbus, the stamp is made over the sclerocorneal junction. This device is a prototype. Further development with appropriate handle will give more ease to make stamping. The sclerocorneal tunnel is being made following the mark. Also, the corneal entry is done following the mark as a guide. We would also like to mention the device named Ranjan SICS marker available in the market to guide the external frown incision. This device is advocated for topical SICS surgery, whereas the device we have made will be more beneficial to the postgraduates and novice surgeons who land up in corneal endothelial damage and high astigmatism due to inadequate side pocket and inappropriate corneal entry. Since the corneal diameter of the goat's eye is larger than that of the human, the internal incision stamp in this video does not seem to reach the limbus, which will not be a case in the human eye. For human eye, we plan to make a similar device in silicone material for an easier use and effective sterilization. To conclude, this holistic device guides all the aspects of sclerocorneal entry and helps novice surgeon to make perfect tunnel and yield superior visual outcome. Thank you.
Constant dilemma which every person undergoing a cataract surgery faces these days. In one of the most transformational times in human history, the technology in ophthalmology is growing leaps and bounds. The expectations of the patients undergoing cataract surgery, as it has been rightly said, that sky is the limit, has reached sky high. They totally want to have a spectacle-free best vision. According to various articles published on the prevalence of astigmatism in people undergoing cataract surgery, it states that 20 to 30% of patients who undergo cataract surgery have astigmatism of 1.25 diopters and 10% have 2 diopters or higher. There has been an evolution in various types of IOLs since the discovery, and to tackle this problem, toric IOLs were introduced. Cataract surgery in small pupil, followed by implantation of toric IOL, poses a challenge for an ophthalmologist. Various causes of small pupil can be advanced age, pseudoexfoliation, uveitis, diabetes, and certain neurological condition. In small or mid-dilating pupils, after the implantation of toric lens, the toric marks of the IOL go under the iris and we are not able to visualize these marks, and hence placement of the IOL in its intended axis is very difficult. During this surgery, there then occurs a lot of manipulation of the iris to locate the marks, which can lead to a release of lot of pigments, increased prostaglandins release, iris handling, and wound manipulation. In such cases, it often leads to increase of the pigment release, leading to post-operative uveitis, IOP spike, cystoid macular edema. It leads to increase in the intralenticular back pressure, which leads to the rotation of the toric IOL. This led Dr. Sri Ganesh very frustrated and into constant thinking that what or how could this be simplified. But one fine day, when he was exercising in his gym, one novel idea struck him. After placing his barbell on the bench and waiting to pick it up for the next set, he saw that it had left a mark on the bench, and yes, that was the eureka moment which made him discuss about this with his colleagues and led to the novel invention of the Ganesh toric IOL marker. The Ganesh toric IOL marker has a lower end plate with 2 windows through which the toric marks can be seen and ridge underneath. it can place a mark either with the indentation or with the help of surgical ink. The holes are then aligned on the toric marks and the marker is pressed upon the IOL for about 10 seconds so that it leaves a mark on the intended axis of the IOL. Then the IOL is loaded in the injector and is further injected in the eye, and these markings along with this IOL mark then are aligned with the help of a markerless system. After performing successfully phacoemulsification in this case, we demonstrate the use of toric IOL marker for the placement of the toric lens. The end plate of the toric IOL marker has 2 holes and a ridge underneath, which helps in the indentation on the toric IOL. After placing the holes of the toric IOL marker on the toric lens, we indent the IOL in its intended axis for about 10 seconds. As you can clearly see, there is an indentation mark on the IOL, after which it is loaded in the injector and placed inside the eye successfully. After placing the IOL inside the eye, the indentation mark, it can be used as a guide for the placement of the IOL in its intended axis using the markerless system, and hence it makes it a very successful, useful and an easy tool. So the question arises, is there any need of using the toric IOL marker in cases of small pupil? And the answer to this question is yes, my friends, because it leads to less of the iris handling, leading to less pigment release, less chances of IOP spike, and even lesser chances of cystoid macular edema, and almost nil IOL rotation, and a very much improved patient satisfaction on the first post-op day. The first post-op day on slit lamp examination showed no scratches or marks on the lens, and the ray tracing was done, and we found 0-degree rotation of the toric IOL, and also the HD analyzer showed no significant scatter on the first post-op day.
Hi everyone, I am Dr. Sumit Vashne, consultant anti-segmental oculoplasty at Alaknen Eye Institute, Udaipur, Rajasthan. This is a heart nucleus with grade 3 to 4 nuclear sclerosis and intumescent status. After making tunnel, side port and staining, I am making rhexis by the help of phacopunch. This noble technique creates a nick, aspirates the hydrated cortex, and suddenly decompresses the nucleus. It gives you a nice nick or punch edge so that you can complete your rhexis with the Uttratha forceps. After completing the capsulorhexis, I am doing hydrodissection, rotation of nucleus. Now comes the main thing. I am using this modified dialer to go underneath the rhexis and holding the subincisional, subtunnel end of nucleus by the bevel end down phaco-tip, and the end opposite to this with the help of my modified Sinskey hook. After holding the nucleus in between 2 instruments, I am trying to crack the nucleus with no ultrasound energy at all. Yes, there is no ultrasound energy at all. Only irrigation mode is on. I will be aspirating the loose cortex in between. The mechanism is the application of forces simultaneously in opposite direction with the 2 instruments. This will divide the nucleus into quadrants and the quadrants into further small fragments. I'll be trying to divide the nucleus into smaller and smaller fragments as much as possible. And the point is, I am not using any ultrasound energy at all. which is usually used during this maneuvering of nucleus management. You need ultrasound energy in trenching, in cracking, in chopping, but here I am not using any type of ultrasound energy. I am just aspirating the cortex to clear the field. Now I am starting eating these small fragments. This further reduces the amount of ultrasound energy. Larger the piece, more the energy. Smaller the piece, lesser the energy. Your ultrasound energy consumption should be minimum during the surgery, which is a crux for the clear post-operative corneal status. With the ultrasound energy, we damage a lot of ultrasound endothelium cells, which leads to failure of endothelium pump and hydration of cornea. See, as the pieces was very small, it take no time to eat these small fragments of nucleus. My nucleus management is done without extra wastage of any ultrasound energy. I use the energy only during eating. This coaxial cortical aspiration and in last, hydroimplantation of posterior chamberal intraocular lens in the back. This technique saves a lot of ultrasound energy and final clear cornea post-operatively. Thank you.
I think both of our anchors are not logged in at the moment. So this is the last category.
Yeah. So the youngsters are waiting for the final round, the results. And they're all logged in, they're anxious. Their fate lies in your hands, Dr. Naushed, Dr. Lalit. Your comments and to declare the winner.
Naushed.
Now I'll comment on all the three. The first one is the SICS marker. I think it's a very useful marker, even though it's not been exhibited on human eyes. It has been exhibited on goat's eye, but still I think it's very useful, especially for a person like me, not only beginner, but a person like me who transited from ECC to PHECO and never learned SICS. So for me, an SICS, doing a SICS is not a thing. I wouldn't be able to do it so successfully. So this would enable me to do it more successfully. And I think it's a good idea. And for beginners, definitely the size of the incision, the frown incision, all this is marked so that that's a good guide for them. And the side pockets also made, so the markers made so that they can extend their side pockets. And it's, I think, a good innovative device. The second is this Sriniganesh. This thing is the case in cases where the pupil gets smaller in toric IOLs. Now, in the pupils that he showed us, I think I would apply a pupil dilator, definitely, like a Maliquin ring or iris retractors or something. But I would not, in such small eyes, I would not attempt. But in case the intraoperatively the pupil becomes small and it's difficult to apply a Maliquin ring or retractors because you might catch the anterior capsule, then it would be a very useful thing while introducing the lens. Also, the impression, I don't know how much it lasts, but I think should last, because in a hydrophilic lens you cannot put trypan blue because that's absorbed by the intraocular lens. And the third one is he mentioned it was a very hard cataract. Now, if it's a very hard cataract, I think without emulsive phaco energy, it's not possible to do almost a zero energy phaco, and he didn't show us the parameters on the screen. Actually, in such a video, when you have anything exhibiting like this, you must show the parameters of that on the screen so that we really know how much energy was used and how much of minimal energy was can you use in such a hard cataract.
Dr. Sumit, you want to say something? You can unmute yourself. Yeah.
Sir, at our institute, we don't have any overlay to show the parameters, but definitely this technique reduces the amount of ultrasound energy as compared to other cases to very less. I am using the ultrasound energy only in eating process.
Now, what did you use in this case? How much was the energy used in this case?
That was 0.45. 0.45.
It is less than 1.
Exactly, sir. Sir, to save energy in soft cataract is definitely easier, but the hurdle is to deal with such hard cases and then finally get the cornea clear.
Yeah, basically what you did was you made very small fragments so that you could use very little energy to emulsify them. So that is what you did. I congratulate you on your surgery. It was a very wonderful surgery and very well done, because you definitely demonstrated that smaller fragments should be made in these cases so that energy becomes less.
And one thing more, sir, I usually we use ultrasound energy at least to impale the tip in the nucleus and trenching and further manipulations. But in this technique, I tried not to use any ultrasound energy till I start eating finally.
But I think, Sumit, if you want to impale and chopping cannot be done so successfully in a hard cataract without impaling. I don't know, that I would not agree with you totally, because without impaling a hard nucleus like this, it's impossible. Only by a suction, I don't think you are able to.
Yeah, I'm not. Sir, I am not.
You have to give a small burst of energy for the phaco tip to go inside the fragment.
No, sir. Actually, I am not using energy at all in all these.
Anyway, it's a very good thing and very good demonstration of a very good surgery.
Yes, a very good demonstration. It's a very good technique. It's a learning experience. It's an innovation, definitely.
Yeah.
And once you add some more features to your presentation, if you could, it would really become an award-winning thing.
Yeah.
Probably it is still an award-winning. I don't know. Dr. Lalit and Dr. Naushir would tell what is the final status.
Dr. Lalit, please announce.
Yeah, I think quality. Firstly, I saw all the videos, actually all the segments, but quality of videos in this segment was the best. I think. I don't know what Rahil says. Yeah. But the quality-wise, the clarity-wise, I could see
yes,
at least
I think
all
very
the
well.
Very good.
Very
all 3 videos. And the expert Naushir has already pointed out the video by Dr. Fatima, Rohan, and Dr. Vashni. All 3 have some novelty or new technique in them.
Yeah.
But I think 13 is not an unlucky number. So video number 13, I think to my thinking and Naushir's also gets the Oscar in this category, primarily because it is simple, effective, and a very useful technique for a very commonly done toric IOL.
Because I think even a small rotation in a toric IOL makes a lot of difference.
Yeah, the implication of that is huge.
Because the expectation of the patient is very great. As soon as you implant a toric IOL, the expectation is that there should be zero residual refractive error, and a slight rotation in these cases, or even, as he said, manipulation of the iris and CME and other things also creates a lot of problems. So I think the smoother the surgery, the better. The only thing where I disagree with him is that I would have used the iris retractor or a malignant ring or some pupil dilating, because the pupils shown were very small. Very small, and he didn't show them being phacoed. So
had Sanjay or Rahil permitted us to give more awards, I think all of them deserve. But if you have to pinpoint one, I think video number 13, the unlucky number, but the lucky guy. Lucky guy is I think about Rohan. Dr. Rohan. Is Rohan there?
Is Dr. Rohan. Yeah, hi,
Yes, sir.
Rohan.
Yes, sir.
Hi,
Thank you, sir. Hi, sir. Hello, sir.
Congratulations.
Thank you, sir. Thanks for
getting the Oscar.
Thank you, sir. Thank you, sir. Thanks a lot, sir.
How do you feel getting this Oscar? Oscar तो बहुत बड़ा तमन्ना होती है ना. It's a big dream.
So it's an unbelievable.
Yeah. So I think hats off to Sanjay and Rahil for having this great idea. I know, Sanjay and Rahil, innovative brains. And they always come out with new ideas. Even in AIUS, when I was chairman of scientific committee, they had wonderful ideas and always had a session in AIUS. So hats off to Sanjay, to you and to Rahil. Very, very great session you have done in AIUS and a landmark, I think, in session in AIUS.
Thank you, Lalit, for those encouraging words for both of us. The father and son are very grateful to you for all that you have done.
No, you
and Dr.
deserve that because
Noshir,
you see, I remember when I was in scientific committee, always there was a demand for that session which you started way back in, I think, Hotel Lalit you started.
Excuse me.
Yeah. Picked up so well.
I was the first Lord.
Yeah.
First Lord.
Yeah. Then Namrata became queen and so many. So in any case, you see, new ideas, innovation, not easy. And now comes the Oscar. So Oscar goes to this category. So congratulations to all the
Sanjay is on a different scale, Oscar scale.
One Oscar for Sanjay and Rahil also.
And another, and three cheers for both of them.
Congratulations.
Thank you so much.
To all the winners. But I think all are winners because, great videos were there. But since there was limitations, so you had to pick up only 4. So congratulations to all the winners. And especially to, I think I'm very proud of Sanjay and Rahil for bringing this session in DOS.
Thank you so much.
Thank you, Lalit. Thank you for the encouraging and kind words. Thank you, Dr. Noshir. Thank you, Namrata. Thank you, Dr. Tityal, and the other participants who sent in their videos. Dr. Bharti, thank you if you are still logged in or listening to us. It was a wonderful session. It was the first of its kind and an online platform. And thanks to Dr. Namrata and all the arrangements she made, it came out pretty well.
Yeah.
Next time we hope to improve it further and take it to the next level. Thank you so much.
Thank you very much, Sanjay. Thank you for inviting us. Thank you.
Thank you. Bye.
Thank you and good night.
Bye. See you later. Bye. No
Bye.
shares.
Bye, Mr. President. Mr. President, sir. Bye.
अरे सर ये तो मुझे अच्छा खिंचाई का तरीका है
Mr. President, sir. Bye. Okay.
Lalit is a
he's
a big tease.
Tease me, sir. What to do, sir? Corona में थोड़ी enjoyment.
हाँ, I know. थोड़ी बात ही कर ले यार.
No, I am expecting Sanjay and Rahil to have some Oscar party today. Maybe tomorrow.
Virtual?
नहीं हट वर्चुअल यार इतना बड़ा काम किया यार.
यहाँ पे दारू डालूंगा अब वहां पे पी लेना.
वो भी तू कर लेगा. चल. Okay, bye.
Okay, bye.
Stay safe.
Okay.
All of you.